lives have adapted to the new normal. After an interval of around 2.5 years, we are all here back, gathered together to execute our fifth CM.
ये लो बेटा, जड़ी बूटी से बना है, फटाफट ठीक हो जाएगी। लो। उल्टी। ये लो।
अपने आप को एक्सपर्ट मानते खाने के पहले दो और खाने के बाद एक भाई
सबको डॉक्टर बनने का बहुत शौक है, पर हेल्थ के मामले में दुनिया की नहीं, सिर्फ डॉक्टर की सुने।
From our college old days, we imbibe favorite definition that cell is a structural and functional unit of life. The Almighty bestows upon a very few good men with a unique lens eye view to handpick some of the abnormal functional units of life. We are lucky to have one such distinguished hematopathologist and flow cytometrist with a shining academic career in the form of gold medal from the Pathology Department of Postgraduate Institute and Medical Research Institute, Chandigarh. I feel extremely honored to welcome Dr. Kunal Sehgal, Director of a standalone, unique hematopathology and flow cytometry laboratory, Mumbai. His craving for excellence instigated him to get trained under the stalwarts of the field of a Tata Memorial Hospital and Johns Hopkins Hospital, USA. His special inclination towards hemato-oncology diagnostics, especially in intricate field of bone marrow and flow cytometry studies, makes him stand out from the rest. It leaves no doubt in my mind that before we leave this venue, we must have refined a basic hematology and will be able to diagnose beyond the horizon. Let our appreciation towards this dynamic personality flow through our clubbed hands. With a huge round of applause, I welcome Dr. Kunal Sehgal.
Thank you so much for a very warm and kind introduction. At the outset, would like to thank Ajay sir and Sagar for having me here, and thank the full Neuberg Ajay Shah team for organizing such a wonderful event today. So the next 25-30 minutes, my task is to take you through some case studies in CBC. As the title says, hematology basic and beyond. I suppose all of us use this test in day-to-day practice, whether we are on the laboratory side or the clinical side. This is a very, very critical test and something which almost every patient also understands today. And like you're always, possessed about mileage of a car, I think I am also very interested in getting more mileage out of a simple test like RBC. How do you get more mileage out of this test? You get more mileage by looking at more information than just the numbers which the machine gives or which the clinician sees. So based on that, around 6 years ago, we coined this test CBC Advance. What does it actually do? What is that advanced word for? Basically, we divide into three parts. A basic CBC with full utilization of different kinds of flagging which comes in the analyzer, whether it's the immature granulocyte flag, the NRBC flag, the other flags which you can build in, different rules. The role of a pathologist, and I was very happy to see the small video we had before we started, that the doctor first, and I would say pathologist still has a role. In spite of all the technology and all the machines, there is a very, very big importance of the peripheral smear, and I'll go to that in our cases. And then highlighting the role of an automated retic count and not restricting ourselves to the retic count per se, but all the other newer parameters which are now available. Now, typically if you ask a clinician and say, if they had to ask one question to a lab about the CBC machine, they will ask, do you use a 3-part or a 5-part? Okay, and then the gauge based on, 5-part, it might be a slightly better lab and vice versa. But it's just not the 3-part and the 5-part differential, it's looking more into the details of the machine which we'll do. So this is the format of a report, the basic CBC report along with additional parameters, and we'll discuss that as we go along with the case studies. We'll try and make it interactive, and I'd like to have your inputs wherever possible. So this is a 22-year-old young boy who presented to the physician, primary physician, with close to normal hemoglobin of 12.9. The WBC count was 48,700 with a platelet count of 229,000. Now, the patient had slight left abdominal pain and on palpation had a splenomegaly. Went to a hematologist, referred to us, the smear came to us, and I said the role of the peripheral smear is very important. Now, I'm going to go back and forth in this slide. This is a peripheral smear for everyone. Other than the routine neutrophils, there are these left-shifted cells which are the myeloid series cells, myelocytes, promyelocytes, metamyelocytes. There are a couple of basophils in the smear. Now, this is what I am seeing on the peripheral smear. But if you go on the CBC, there are a lot of flags below. It will not be very clear, but there is an IMM grand flag or a left shift flag, which is basically an immature granulocyte flag. The current day counters can identify that in this patient there is going to be immature granulocytes. Now, immature granulocytes means left shifted myeloid series, does not really mean blast. You may or may not have a blast which needs to be confirmed in the smear. But immature granulocyte flag is very critical to us in our lab, and if it's more than 1% by the machine, it is a peripheral smear review criteria for us. That means this slide has to be screened. Now, typically, you will see that most commonly in infections, patient in the ICU, sepsis, you would see your UTI, you might see a little left shift. Once you start seeing left shift with NRBC, you're thinking of a stressed marrow. And other than infections, you need to look at other causes which are there potentially in the bone marrow. Not to forget some physiological causes, especially pregnancy. In pregnancy, you can see 1 to 2% myelocytes or metamyelocytes, which is normal. Okay. Now the challenge is once you put in a pregnant lady 1% myelocyte, there is a lot of anxiety, both with the patient and the gynecologist, but we need to let them know that this is normal. So while useful, you might pick up things which you're not picking up earlier, but use it judiciously. This goes for all the flags and all the parameters. So this guy had a splenomegaly, a very high count. By the time he came to us, his count had already jumped to 1,12,000. This is a 1 week difference. We saw the peripheral smear, there was left shift, there was basophilia, there was a splenomegaly. The age was very odd, he was just 22. A bone marrow was done, it was packed with cells, megakaryocytes, a lot of basophils, few blasts. So what would be the diagnosis? CML. So chronic myeloid leukemia are looking for. So we did some fish and cytogenetic studies, it was positive for the classical Philadelphia chromosome, which we all know. It was a classical CML CP, we did the biopsy. But my idea of showing this case was not that. My idea was to look at more in depth in the CBC to what information is available. So if you go back to the CBC, the hemoglobin was 12.3. Earlier was 12.9, so almost similar. But you look at the indices. MCV is 61.1. RBC count is 5.92 million. This normal hemoglobin for a male is around 13 to 16. You might say just borderline low, patient has a CML, which is a malignancy, it might be low below that. But the indices are not explained by the CML. So with these kind of indices, anything the patient might also be having in addition to CML. Anyone? So excellent. So we are suspecting a THAD trait. So there were target cells on the peripheral smear on the RBC, and in our system we have all the different flags and rules, and now currently analyzers allow you to put the formulas inside the system. One of the most popular one throughout our learning division, the Menzel's index. We have published this, the Sager index which we use, where we take MCV square by RBC, which you multiply. If it is less than 972, it is suggestive of beta thyroid. So this formula is there on our machine itself, different rules, and even the technologist gets to know suspect a thyroid in this patient. So we suspect a thyroid, so typically you do an HB electrophoresis, or the current method is the HPLC. We did that. To our surprise, there was a S window or a sickle window of 19%. Now, we are thinking of thyroid because of the microcytic hypochromic indices, and we saw S window. So this patient appears a normal hemoglobin, A2 is almost close to normal 3, and S window is 19.4. So looks like he's a sickle trait. The challenge is two things are happening. Sickle trait, those indices don't explain themselves. Why are there microcytic hypochromic indices? Because sickle trait doesn't have it. Secondly, sickle trait is always 30 to 40%, not 19-20%. So when it's low, one needs to be aware that this is not simply sickle trait, there could be a concomitant alpha thalassemia. We got him tested, there was an alpha thalassemia deletion. So to conclude, this patient not only had a CM and CP unfortunately, but is a known case of sickle trait and an alpha thal trait. And all this came not from doing specialized genetic molecular testing, which was done later on, but purely from very basic information from your CBC report and getting it done. So this is important because CML has its own treatment, but you need to also be aware of the sickle and alpha thal or the beta thal for the siblings and the family screening. So that is the takeaway message from this particular case. Now we move to the next patient. This is a 6-month-old male child who was referred to us for anemia workup. Now the first thing you see, hemoglobin is definitely low, 6.9. No doubt that this is anemia. WBC count is 20,650. Now this immediately strikes to us as a high WBC count, but keep in mind, at that age of 6 months, almost up to 18,000 is close to normal. The patient on the smear had almost a normal differential with predominantly lymphocytes, few neutrophils, and nothing major other abnormality. Platelets are 2,87,000. So we are dealing with isolated anemia. Okay. As a habit, as pathologists, we look at the graphs. And what I wanted to focus is, because an automated CBC was run with automated retic count, there is a retic count values over here, and I don't need to go to the details. The retic count was 11.91%, which is definitely high. Even the corrected retic count was high. So you are having a 6-month-old child, isolated anemia with a high retic count. So you are thinking some form of hemolysis, blood loss kind of a picture. No clinical evidence of blood loss. You are looking at some form of hemolysis. So that's where the role of the pathologist immediately comes in, looking at a very good peripheral smear. So for the people in the audience who are pathologists will know this, but for the clinicians, these dark, round, small spherical cells, the ones which are dark, are actually all spirocytes. Comparatively, this is like a normal cell, which is we call normal chromia. This is a slightly larger polychromatic reticulocyte, and there are many dark brown cells, the spirocytes. So this smear was full of spirocytes in a 6-month-old who has a little jaundice, unconjugated bilirubinemia, and has hemolytic anemia. So what are we thinking of clinically? We're thinking of hereditary spherocytosis, and typically, if I may ask, most common test one would next advise for would be osmotic fragility. So two things you have to keep in mind for people who have actually sat and done the osmotic fragility test, and I'm sure the lab staff here will agree, is one of the most cumbersome assays, very time consuming, very tricky, has its own false positive and false negative ratios. Also, it is purely a screening test. Just because it's osmotic and spotted is not HS. So things have moved, and as both on the lab and clinical side we need to go and forth. So we have standardized this test in our lab now, which is called the eosin 5-maleimide test. Short form is EMA. Now this is simply a dye which goes and binds to the RBCs, and we use it by flow, and I'll show this test to you. So without going into technical details, we always use 4 controls. These are the 4 controls. We put the dye, if the cell size is normal and the cell structure is normal, almost all of us, if you were to use our sample as control, will have equal binding of the dye. In a patient with spirocyte, the cell becomes small, there is a band 3 protein which is lost, so the binding is lower. So if you see, this is the patient in red, and if you see this photograph, all the 4 samples have been overlapped. So this is the normal expression, the red is lower expression. We do some calculations based on the expression, and if there is reduction more than 21%, it is practically hereditary spherocytosis. So the idea is, again, we started from having a combination of a CBC. At 6.9 hemoglobin, you would have said, okay, investigate, refer to hematologist. But at the lab angle, we saw the smear, we saw the the retic count high. We advised that okay, we need to do the EMA. It was done the same day. Very importantly, if you think osmotic fragility is heparin sample, needs an additional collection of a 6-month-old child. And for EDTA, for the EMA test, it's an EDTA sample, requires 5 microliters, can be done with capillary collection or your leftover CBC sample. So just highlighting that, picking that up on the CBC itself can lead you to a proper diagnosis, which is almost instant, the same day or the next day itself. So that was the second case. Now we move to the next patient. This is an 8-year-old male child. He's had fever for the past 1 week. He's being treated for nephrotic syndrome, was in a government hospital, went to a private pediatrician with complaints of wheezing and difficulty in other feeding and everything. So the pediatrician rightly suspected, is there an underlying pneumonia? He said, let's start with the basic investigation, CBC, ASR, chest X-ray, very standard investigations. And the CBC came to us. Now, if you look at the CBC, and again I'm showing you the machine photographs, not the report, so that we can look at different flags which the machine gives. The patient had a hemoglobin of 12.1. In the background, there are indices that suggestive of an underlying thal trait. I will not go there for this case, but they were also there. WBC count is 16,000. He had around 75% or so neutrophils even on the smear. Platelet count was 1,81,000. So upfront, when you see this, you will say, okay, sounds correct, slightly high NSR, chest infection expected. There's a neutrophilic infection in the background, which he's having. But when you look at the flags, and this is where different flags and the graphs for us become very critical. There is a flag which this particular analyzer we use, and now many analyzers have this flag. It is called as the PRBC or the IRBC flag, or the infected RBC flag. Now, again, because this is new, there is a small cluster of purple events which are seen extra in this graph. And this PRBC flag basically identifies presence of malaria in the CT sample. Now, that comes free of cost. There is no retic to be run, there is nothing to be run. You are not clinically suspecting also in this case. Incidentally, this case actually had, and this is not the takeaway message, but this case had a mixed infection. Both, there were ACOL forms, these are the gametocytes and the schizons, and there were some ACOL forms confirmed on the rapid manner. There was a mixed infection in this case. So the idea is not to talk about the mixed infection. The idea is to say these machines start, now with the current technology, they can pick it up. So when we learned about these machines, we realized that there is a flag or a Q flag screen, which there is a weightage given. If the value is more than 100, the machine will flag it and say screen for malaria. It's not a confirmatory test. We did a thorough study. This was in my older machine in around 2016. So we said, how sensitive and specific is it? Because if I'm going to use it for the patient, I need to know in my own environment. We took 667 cases which came in that 2-month period for malaria. 68 were positive by your routine peripheral smear, the rapid malaria test, whichever is available or both. This flag was positive in 57%, 57 of the 68. Okay, 11 of them were negative on the CBC analyzer. Remember, it is not told to look for malaria, it is giving this as an additional information. So even 57 out of 68 is excellent. Current flag had a sensitivity of 84%, specificity of 99%. Maybe we see false positive in degenerated samples, in samples with hematolymphoid malignancies, and it is pretty rare, and I use this flag for now almost 6-7 years, very rare. Currently picks up only P. vivax, a rare gamete of falciparum. There are other flags in systems of falciparum, but this does not pick it up. So I was more interested in the other 11 cases. What is happening? Why are they negative? So I went to the Q flag screen and said, okay, let's start seeing the numbers, because the cutoff is 100. In majority it is 0 or 10. So what happens to the numbers between 10 to 100? And what we realized, 9 out of these 11 cases had a Q flag value which was between 20 to 90, but it was not 100. So machine was not sure. That's how the company has done its default settings. So this is the case just last week, the beginning of our monsoon malaria season. Again, a patient was a normal hemoglobin of 12.9, normal WBC count, and had fever, borderline platelet. The doctor only sent for CBC and get your COVID RT-PCR. That's typical because we are having that season. And there was no suspicion. As a rule now, our staff is trained that in every case, even if the machine is not flagging anything, go to the Q flag screen. In the Q flag screen, the IRBC was 60. Okay, it is definitely more than the lower cutoff of 30 in our lab which we use. 60, we screened the smear, we had PY-vax over there. Okay, again, just to highlight, knowing the technology available, then using it judiciously and putting into practice with confidence of having done the study, purely based on the data analysis given by the machine. So the take-home message, this is not a confirmatory test, this is purely a screening test, extremely useful, free of cost along with the CBC analyzer, and warrants confirmation by microscopy or rapid molecular test. We move to the next case study. So these are two made-up cases, okay, to highlight important fact which we use both in the lab and the clinical side. Everything is same except for two findings. Here, normal hemoglobin close to normal platelets, WBC is 3500, here WBC is 35,000. If you see the differential is the same, 65% lymphocytes here also and 65% here also. So what is the difference? Here the absolute lymphocyte count is 2275 and here the absolute lymphocyte count is 22750. Now the moment we see 65% lymphocytes, we use lymphocytosis. So is both lymphocytosis? The difference is on the left you have relative lymphocytosis with a leukopenia, a slightly low count. On the right you have an absolute lymphocytosis. Now this is the question both on the lab and clinical side we always need to answer. Very easy information is available from the cell counter, both on the reports also. Nowadays almost all labs are giving the absolute counts also. So the reason is relative is totally different etiologies and absolute is totally different etiologies. And again to highlight a case, sort of examples for you. This patient, for example, is a normal sample of 8,000 WBC, 60 and 30 neutrophil lymphocyte differential. The absolute counts are normal. You move to case 1, close to the borderline edge of lower side of normal WBC count. Now has 30% neutrophil. Absolute neutrophil count is 1200. Now cutoff for neutropenia is 1500. Typically in adults, clinical cutoff is 1500. So this patient has neutropenia, no significant lymphocytosis. You might label it as slightly relative. You move to the next patient. This patient definitely has leukopenia, 1500 count. Neutrophils are only 10%, so absolute neutrophil count is 150. Severe neutropenia, no doubt about it. The moment you see lymphocytes, they are 90%. The absolute count is only 1350. So this is not absolute lymphocytosis. This is purely relative lymphocytosis. This could be a case whose marrow is suppressed because of chemotherapy, or is a case of aplastic anemia, or a severe marrow infiltration, or something. But this is relative lymphocytosis. The last case, 10,000 WBC count, 70% lymphocyte, absolute lymphocyte count is 7,000. So what I wanted to focus is the lymphocyte percentages have, here is 70%, it is absolute. Here is 90%, it is relative. So you need to focus on the absolute lymphocyte count also along with the percentage and the WBC count before we interpret it. So the cutoff at which we call something as absolute lymphocytosis is 5,000 absolute lymphocyte count. This is important because once we see absolute lymphocytosis, we need to check, is it transient, is it sustained? Now, we see a lot of EBV infections, infectious mononucleosis, especially in adolescents, school-going children. You will see some form of viral infections causing such, transient, which last for 15 days to a month also. Lymphocytes take time to recover. But in an elderly patient, if it's sustained, means over the last 3 to 4 CBCs done every fortnight or monthly, you're seeing a sustained lymphocytosis, which is crossing 5,000. It could still be benign, it could still be malignant. Okay, so we don't jump and say, okay, this is malignant. And a typical thing, lymphocytosis CLL. We do not put CLL on our report. We say lymphocytosis. Once we have ruled out reactive causes, and there are many of them, and I'm sure clinicians over here will definitely know, things which is unusual, which we often see in practice, chronic smoking history, we don't think, but there is relation especially to lymphocytosis. A lot of autoimmunity, we see a lot of LGS, reactive lymphocytosis, and it sort of persists for a long time in that 60-70% range, and people get worried, and we often get reviews for that. Now, this is another case study which came out of something similar. 72-year-old, he had persistent lymphocytosis with mild anemia. Hemoglobin 11.2, MCV hovering around 97, close to normal vitamin B12 levels, those are all sorted. The WBC used to range between 9,500 to 12,000. The lymphocytes would range 42 to 58% of the highest. So when it came to our lab, the WBC count was 10,850. Lymphocytes was 50%. So if I do the absolute lymphocyte count, it was 5,425. So it was more than 5,000. There was sustained lymphocytosis. Elderly gentleman has some mild anemia, and the hematologist said, I want to do a flow cytometry analysis because he has ruled out all the benign causes, and was sent to us for the flow analysis. Now, without going into technical details, in the flow, we looked at the lymphocyte population. The red ones here are the B cells. They were 36% of all lymphocytes. Green are the T cells, CD3 and NK based on the 1656 for the NK cells. In the B cells, we had two populations, again red color and the blue color. On kappa and lambda, these were polyclonal, that means the blue ones were normal. But the red ones were clonal with lambda light chain expression. And these cells were expressing 5, CD23, we are expressing 20, 19, had a combination of 43 and 200, which is a classical CLL phenotype. Okay, so do I jump the gun and say this is CLL? Not really, because this patient we are dealing with a very borderline count. So what we do is we do a percentage calculation, and it's very simple maths, but we need to do it. 50% of all WBCs were lymphocyte, so 50% of 10,850 was 5,425. We took the percentage of T cells, 60% NK4, more importantly B cells were 36%. So the total clonal B cells were 1953. Okay, now I used a cutoff of 5,000 for absolute lymphocytosis. The cutoff for definition of CLL is clonal lymphocytes should be more than 5,000. So here the clonal lymphocytes are definitely less than 5,000. The idea to highlight the importance in this case is not every lymphocytosis, even after being clonal, is a malignancy. This is the condition called as monoclonal B-cell lymphocytosis, which is query pre-malignant. We don't even know if it will actually go on to become a CLL. Okay, 1% of the patients of MBL may progress on an early rate. It's a very, very low percentage. One should be aware that these conditions exist. So there are a lot of diagnostic criteria. You need to do a CT scan, PET scan, evaluate this patient, rule out lymphadenopathy elsewhere before we label them as MBL. But if you have to flow people above the age of 65 to 70 with 9,000, 10,000 counts, you might pick that in a very significant percentage. There are studies all over the world showing this. But the problem is labeling somebody with cancer and MBL is totally different. So one should be really aware. So again, there are a lot of conditions which you see on flow, reactive, benign, sustained lymphocytes like MBL or a frank CLL or a mantle. But we need to go to the next step and pick that up. So idea was to basically highlight relative lymphocytosis absolute and the etiologies and the approaches different. The last step which I will do or the couple of cases is all about IPF, and sir specifically asked me to discuss this condition, a very popular parameter across board these days is the immature platelet fraction. Thank you. So we just go to the background of what is normal thrombopoiesis. We know about erythropoietin for hemoglobin, which comes from the kidney. And we know CKD patients have anemia because there is lack of erythropoietin. They are injected erythropoietin injections and they do little better. Same way you have an enzyme called thrombopoietin which comes from the liver. Similarly, in chronic liver disorders like cirrhosis, patients have thrombocytopenia. Clinicians I'm sure have heard of the drug romiplastin, which is a thrombopoietin analog given to these patients. So basically, we have a inverse relationship with TPO and platelets. If the platelets are very high in the body or normal in the body, there is TPO binds to the platelets, less TPO goes to the bone marrow, so you have less production. The moment in the peripheral blood, platelets are low, there is more TPO available because it's not bound to the platelet, it goes to the marrow and it stimulates platelet. It stimulates platelet production. So typically what you will see is that this is all the technical graphs where it is, but coming to the pathogenesis, if you have peripheral destruction, increased destruction or usage, your immature or reticulated platelets will increase in the blood. More immature young platelets are now coming out. If the marrow production is suppressed, aplastic anemia, bone marrow suppression, chemotherapy, they will be reduced. It's also a very, very good indicator in patients of bone marrow transplant where bone marrow regeneration is happening. So we use that. We established normal ranges on different machines at my previous place of work, also at my new machine. So this is important because every company, there might be 3 companies having this parameter. Unfortunately, the algorithms are different, the reference ranges are different. So we need to define what reference range we are using. And these are just some couple of small cases. This is a case of ITP, 15-year-old female with petechial rash, had a thrombocytopenia of 25,000. The IPF was 20%. So as expected, ITP is peripheral destruction, marrow is regenerating, throwing out platelets. This is the next case. This is a 21-year-old case of ALL post-chemotherapy. Platelets were 19,000. IPF is very low at 0.9%. So clinician here knows clinically if a transfusion requirement is there, he or she will transfuse this patient because the IPF is still very low, the marrow still remains suppressed. Now IPF should not be used as a decision maker for blood transfusion. High IPF, low IPF does not, so it's sort of also abused sometimes, should not be using it. IPF has been used by us in dengue and a lot of viral infections. Why? Because dengue also has immune thrombocytopenia and the periphery destruction. How we used it, we published this in our paper. What we did is, we followed dengue patients over a period of time. So you see this is the platelet count on day 1 of admission to day 6. It moves from 89, goes lower to 54. So the blue line is platelet, it keeps falling, reaches a lower level and then starts increasing. Now the pink line is the IPF. So ideally IPF should be done like a trend analysis, like part of a routine CBC, not one-time value is not useful. You need to see a trend. If you see IPF increasing when the platelets are falling, you know the body is actually trying to do its best to throw out more platelets and doing justice to the patient. In a very rare case of dengue toxic syndrome or HLH or a dengue marrow suppression, you might see IPF low. Similar graphs you get with the WBC counts also with the platelets in IPF. You have different parameters one can use. The idea is we were trying to predict if IPF is showing a rising trend, we are likely to have a platelet recovery happening in this patient. We predicted some things that 24 to 36 hours, once you reach a high IPF, you are bound to get a platelet recovery. This was an added value for the clinicians. So one last thing I would like to highlight about IPF, just like a platelet count is not reliable when you have platelet clumps, IPF is equally unreliable when you have platelet clumps. Just like on all counters all over the world, that value below 10,000 of platelets or below 5,000 of platelets is not reproducible. You may do in the best of counters, that's the lower limit of technology. The IPF is also not reproducible. So it is not a replacement of clinical judgment. It is not to be used injudiciously. It's a good parameter if used in such scenarios. With that, for want of time, I will not go to the last case. I would just like to thank all of you for your patient listening, and thank you so much for this opportunity to speak. Questions now or?
Yeah, now.
Okay. If there are any questions, I'll be happy to take them. Yes, sir.
Mike. How does IPF compare with MPV?
So a question is very commonly asked. Both are actually, MPV is mean platelet volume, basically tells you about giant platelets, which you also see on the smear. And though the term is immature platelet fraction, actually they're not really immature, they are giant reticulated platelets. They almost always go hand in hand. One advantage is that in many machine models where a platelet count of below 30-40,000 gets voted out, where the graph is not clear and there's a zigzag line of platelet histogram, many machines will not report the MPV value. Having said that, do I always need a IPF in every case? No. You can, a good peripheral smear where you are visually seeing a lot of giant platelets can do it. It's only that it gives an added number which is a little more reproducible than your and my eye, which is assessing the giant platelets. So yes, they always correlate. MPV, giant platelets and IPF will almost always go hand in hand. That correlation. Yes, please.
Thank you. That was a very enlightening and an interesting talk.
Thank you.
My question was on the IRBCs that you mentioned.
Yes.
Are these specific to only parasites, or is there any correlation with other infectious syndromes?
This particular IRBC flag has been verified and validated by the company and by us in our lab only for P. vivax. We have done some studies on P. falciparum also, but a similar flag has been done in the retic mode, so it comes at an added cost. There are newer day analyzers which are coming as only a malaria-based CBC analyzer, which has been designed only for malaria. While a similar flag doesn't exist, we have a lot of things which we keep doing based on the position of the lymphocytes, position of the monocytes, trying to differentiate an atypical lymphocyte is a very common used word which we avoid. We try to see these are reactive lymphocyte plasmacytoid cells, we know their position. This happens in dengue and dengue-like viral infections. Versus abnormal leukemic or lymphoma-based lymphocytes, they have an abnormal location. So ultimately now, the machine, how did it come across this? This was actually, if you see the history of these analyzers, when there was malaria infection, machine would wrongly overcount the WBC count. So the companies realized in every malaria case which is heavily invested, our WBC count is high because the scattergram goes wrong. So everything lies in the scatter plot. So we use a certain properties of the positional cells. So there are some studies now on typhoid showing something, dengue showing something, specific infection showing something, but it's not all infection as common as malaria. So that's the challenge. Yes, sir.
So, can you depend on the IPF? Can you depend on the IPF when your patient is recovering from the dengue? How much to rely on it? Because there was a graph which was showing in the center, showing IPF increasing, but the platelet was still going down.
So, while the platelet is going down and if the IPF is increasing, it's actually a good sign. You want that to happen. So I'll just go back to the graph.
That is showing the prognosis, no?
Which is a good sign. So, so if it is going up, typically it means as the platelets are falling, the bone marrow is producing more immature platelets, so it is giving. So if you had taken only these two values, you would not get this information. But if a CBC IPF was done regularly for these admitted patients especially, you may have, or at least an alternate day CBC or with an IPF and a routine CBC to see what is happening with the IPF, we typically see this trend. Once the platelet reaches lowest, that's typically the time when the IPF is at its highest. Now, many people ask, but I need a one-time value. I would say at least it should be 10% and above for it to be significant. But the challenge is when I show the normal range is 1 to 6. For me, from 5 to 10 is an increase, and for you, 1 to 7% is also an increase. That's the challenge with single time value.
The reason is that can you keep on hold for platelet transfusion in case if IPF is showing improvement?
So two things. One, transfusion is purely a clinical decision, irrespective of the platelet count or the clinical picture. Generally speaking, most physicians will advise no transfusion in cases of dengue unless there are other reasons to do so. Third point, it generally gives, what I realize in practice is, clinicians and physicians said, it gives a number to allay the fear of the patient. Because patients read Google, WhatsApp and come and they are like, humko transfusion do. So this really gives confidence to the clinician and the patient. It's okay, your results are looking fine, you don't need to worry about this transfusion. So that's the way I would put it. The decision still remains with the clinician based on the patient and not on IPF.
Besides that, you will need to know what is the break point for the transfusion, no? Because if you start going, hematologists, they mention that if platelet comes down to 10,000 or so, you can
Correct.
still hold on. If there is no hemolytic,
Correct.
if there is a hematuria or whatever.
Very true, sir. So only below 20,000 is when you start thinking, and as you rightly said, most hematologists will not transfuse till it reaches 10,000. And there also they will say with bleeding manifestations. The challenge is below 10,000, the IPF will not be very useful.
There.
Below 10,000. But you will still have a sequential trend by then. The marrow has been responding, it's been doing well. And also you look at the clinical picture, the WBC count. If all WBC is low, platelets is also very low, you are worried in those patients. Once this WBC starts recovering, in our experience, within 24 to 36 hours, platelet will also recover.
No, but many times they may do mention about the platelet.
Yes, sir.
The size of the platelet is more than what it is.
Correct.
So we believe that it is improving.
Definitely. So giant platelets on morphology, a high MPV as sir said on the report, and a high IPF or a rising trend is very useful in practice.
Thank you, sir.
Thank you.
So optical platelet is better than manual platelet count on peripheral smear. Do you advise optical platelet in old patients?
So my question is, when you say manual platelet count, everyone, the clinician, the pathologist and the lab have a different meaning. So what do you mean by manual platelet count, if I can ask you?
On peripheral smear.
So that is not a manual platelet count. Manual platelet count by definition is a Neuberg chamber count, which practically none of us do. In our lab, we label it as peripheral smear estimate. We don't even label it as peripheral smear count. And it is extremely subjective. It is extremely variable. Size of platelets vary. Two things I will say here. If there are clumps, no count is reliable. Whether it is peripheral smear, manual Neuberg chamber, optical or impedance. Within impedance and optical, especially in cases of giant platelets, where the graph of the impedance you can make out, and that's a separate talk altogether. You can make out from the graph that this is the unreliable count. The platelet count by the machine might be 20,000 on the smear, you feel like 80, 90 on that bigger difference. In these cases, the optical count really helps. Okay? But that does not mean that optical count is always good. At the higher level, the impedance is actually better. So use it judiciously, that's my message. But there are a lot of advantages of doing these parameters. So when we do the CBC advance, we get the impedance, we get the optical, we do the peripheral smear, we look at all three and correlate. So with that experience, we can pinpoint and say which is better and what is good for the patient. But we typically tend to go by the machine count unless there is more than a 50% difference between my peripheral smear estimate and my machine count. I won't change the report at all. But that brings in a lot of subjectivity. The bigger the lab, the more the doctors in your lab. Same slide, you will see third day, fourth day, you give a different platelet count. That's the challenge.
Thank you, Dr. Kunal.
Dr. Ajay Shah's lab and good lab, when there is a thrombocytopenia, and especially in a case of dengue, they do mention large platelets.
Correct, sir.
So suppose platelet count today is 50,000, tomorrow is also 50, yesterday was 50,000, today is 50,000. But if large platelet increases, I believe, it's believed that, probably the bone marrow or rather the platelet count is likely to increase.
Correct.
And, it will be upward trend rather than going down.
True, sir.
So your comment.
So same thing which I said in the IPF, when we see giant platelets in the smear, we are not quantifying it. We are only qualitatively saying giant platelets is there. The advantage of looking at the MPV and the IPF and both together is that you get a number that, it is actually increasing and this is the percentage of all platelets which are slightly larger. So it just is an additional value. But you're right, once you have giant platelets, typically in a low platelet count, we feel that the marrow is recovering and responding to the peripheral destruction. So always good for the patient that way. Versus the patient who has very small platelet, doesn't have giant platelets. Again, amongst pathologists, there is a lot of subjectivity in what to label as a giant platelet. That's a different ballgame altogether, but one should be aware of this. So you're right in that sense. It is good for the patient. Thank you so much, and we'll hand over to the team. Thank
If
you.
there are any more doubts, we can solve over the lunch break. I now call upon Dr. Ajay Shah to felicitate Dr. Kunal Shah. Dr. Kunal, Kunal Sehgal.
Thank you, Dr. Kunal, for this lucid and informative talk. I call upon stage our next speaker, who is Dr. Rupa Vishwanathan, a very enthusiastic and very dynamic microbiologist. She is a founder and managing director of Polylife Diagnostics and joint director of Polylife Brain and Spine LLP. About Polylife, she is one of the first lab which is ICMR approved for COVID-19 testing. She is MBBS from Grand Medical College and MD from Sion Hospital. She has done her FRC PAT from UK. She is a founder and treasurer of Society of Clinical Microbiologists and is an executive member of Hospital Infection Society Mumbai Forum. To tell you very proudly that she is also the winner of Women's Empowerment Principles Leadership Award organized by ET Now for the year 2021-22. Thank you.
Thank you, Prasida, for that introduction. First of all, I would like to thank Dr. Ajay Shah for it's like a homecoming for me. I'm coming after a decade to this part of the town. In fact, it was such motivating that I got my husband also ready to come down to this part, and I really thank Dr. Ajay Shah for giving me the opportunity to come here. Let me make a small, kind of a confession that this was a talk that was made, this was what I presented around 2 weeks back. And it was highly motivating and very inspiring when Dr. Ajay Shah asked me to come and speak on this, with a little tweaking that I have done on the basis of the crowd that we have today. And I would also like to thank him again for giving me the opportunity to address this august audience who has taken their precious Sunday morning and have come down here. So thank you so much. So without much ado, let me start with the topic. As you can see, what I'm going to speak about is the applications of molecular diagnostics and nucleic acid amplification test. The moment we hear these words, some of us are taken back to the second MBBS course, and we are worried about, or we're getting a little dizzy about thinking about moleculars and genetic testing and whatever. But 2020-21, think about it. What happened? This one virus which brought the entire world to the feet. And this was the year when RT-PCR became a household name. Everybody knew what is RT-PCR. Even a 6-year-old who was attending classes on virtual platform also started talking about RT-PCR, though they wouldn't understand what exactly it is. But nevertheless, RT-PCR became a household name. Now, to those microbiologists, I have some colleagues in the audience. I have Aruna Pujari there, I have Prasida, I have many others. About 2-3 decades back, for a generation which has been fed on Koch's postulates, we always thought that culture was the gold standard. Till this pandemic happened and we were told COVID-19, the gold standard for diagnosis is RT-PCR. So molecular diagnostics has come a long way, and what really happened around this time, or rather for when you send a sample for microbiological analysis into a lab, the maximum that we can grow is either bacteria or we can grow fungi. But viruses, they are very cumbersome. It's extremely cumbersome to cultivate the organisms, and by the time we do come across or we grow the organism, the patient is already fine. And also, it depends upon the capacity of the lab whether they can do the the viral cultures. So having said that, the one resort that we have for the diagnostics of such group of organisms, that is the viruses, we have all turned down to or moved towards molecular diagnostics. Also, one great advantage of the molecular diagnostics has been the turnaround time. So the results where you have to wait for 2-3 days or maybe multiple days has come down to 2 to 4 hours. So you can get the results within 2 to 4 hours. So the turnaround time has been the biggest factor that has helped us, and that is where molecular diagnostics has really bloomed today. Another thing that happened during the pandemic is that there was tremendous demand for diagnostic kits. There was demand for your PPEs, your gloves. So one thing that really, to counter the demand, the one thing that really came up during this period is Make in India technologies. And many of the companies or many of the manufacturers within India rose to the occasion and they came up with their own technologies, which really helped us to maintain the flow of the services. And that I can tell you very proudly that during the pandemic, when we had lots of issues as far as the supply of the reagents and everything, I had no difficulty. I am supporting a Make in India technology, and I had no problem as far as the supply chain was concerned. My demands, my supplies, everything was fulfilled, and I had no breach in the cycle of my delivery of services. So having said that, now when the lecture that I was taking almost a couple of weeks back was emerging trends in molecular diagnostics and nucleic acid amplification tests, and when I was doing certain research, what I realized is that, look at this. This is a Global Market Insights Inc., which was published in Jan 2021, and it says that the global molecular diagnostics market size is anticipated to cross 15 billion by 2026, and rightly so. So many molecular laboratories have sprung up or mushroomed in not only in Mumbai, in India, outside the world to meet up the demands. COVID definitely is going to only be a part of the services that we'll be giving. So this molecular diagnostics, whatever has now emerged, it will have more applications for sure. So lots of research and development has taken place. There was a time, a couple of decades back when we were students, we were also looking at molecular diagnostics with a skepticism, whether this would help us to come to a proper diagnosis, because there were thoughts about this picking up the dead organisms and are we over-diagnosing. But over the last many years, or rather a decade or so, we have seen that there is a huge utility to this particular technology. Infectious diseases have been infecting mankind since times immemorial. There is a huge, we are coexisting with them. We have lots of organisms in the environment. It's only a part of them who are really pathogenic. And this battle with them is going to continue. So the prevalence of infectious diseases are going to be there. Over the last 2 decades, we have seen outbreaks happening at regular intervals till the final blow of pandemic happened about 2 years back. So there is a rise, there is a prevalence of the infectious diseases, and another thing that has also arose out of all this is point of care diagnostic systems. And this is where molecular diagnostics has come in a very big way. So you have the testing facility at the point where you require these services to be provided. So that is what is known as the point of care diagnostic solutions. So what is this nucleic acid amplification test? It has got very high sensitivity, it has got very high specificity, and the results are extremely superior quality. And CDC, so much so that CDC has mentioned that you have to use these diagnostic techniques for influenza, malaria, and trichomonas. So what molecular diagnostics has, it has got lots of applications. As you can see, it has got applications towards environmental testing and industrial testing. But what we are dealing with is the diagnostics, so infectious diseases, as I mentioned, especially for organisms which are not cultivable, which are not culturable. Also for blood screening, genetic testing and oncology testing, molecular diagnostics has got a big role. Now, when we are looking at the clinical testing, molecular diagnostics can be used for the detection of genetic disorders and diseases such as sickle cell anemia, Fragile X syndrome, detection of the mutant gene variants that leads to disease progression, detection of genetic abnormalities such as gene fusion, gene deletions, gene amplification, drug resistance, which is a very, very important aspect as far as critical care is concerned, and detection of inflammatory markers such as interferon, alpha, gamma, interleukins, and of course, being a microbiologist, this is the area that our focus is. So what is nucleic acid amplification test? Simply put, just look what happens here. You have a sample, there is a pathogen, which we are expecting it to be there in the sample. There, we lyse the organism, extract the nucleic acid from the organism. These are then amplified, and there is a signal which will show the presence of the organism or not. It's as simple as that. Okay. Now, so what we have currently there is, we don't have to mention about it. Currently, there is so much of information as far as its utility in TB diagnostics, multi-drug resistant, and as well as XDR TB diagnostics. But having said that, this is something which has to be done along with, there is a group of tests that needs to be done. You can't just completely rely on molecular diagnostics for TB. You must follow it up with culture diagnostics, which is still the gold standard and something that you can fall back on. Okay, it has got a huge applications as far as respiratory viruses is concerned. We were using it for H1N1 viruses any which ways before, and now of course COVID-19 is another thing that has been added on. MDR genes, multi-drug resistant genes can be detected by molecular diagnostics, and this will help in management of critically ill patients, and you can probably help in saving lots of lives. Clostridium difficile is another thing where there is current application. So besides that, now yes, we have lots of diagnostic tools available, but unfortunately these are some of the tests. When we do multiple tests, the time consumed is more, the cost which is incurred is more. But in a patient who requires urgent decisions, there is one thing that I want to imply or rather emphasize on, that is a syndromic approach. So when you have a patient with a respiratory disease and you have a specimen, a single specimen, if you have that single specimen, either a sputum or a respiratory specimen, if you can check for multiple organisms from that one particular specimen, not just bacteria, but fungi, viruses, all these can be tested from one particular sample. It would save a lot of lives and lot of precious time. So that is exactly what I'm talking about when I'm saying syndromic approach, and it is very important, especially in cases of meningitis, where you have precious little sample of the CSF and you can do multiple tests from one particular that sample, not keep on sending that sample to different other centers for different other tests. So if you're looking at a microbiological aspect, then you have one sample and you can look for multiple organisms. So this is what I'm talking as far as the syndromic approach is concerned, and this is something which is going to help us in a very, very long way, in a major way, and we'll be able to save a lot of lives. So what is this? Syndromic testing, there is the BioFire film array that is available. So you have multiple panels, that is respiratory profile, pneumonia profile, meningitis profile, GI profile, blood culture profile. Now what I mean by multiple organisms detected in one, just to make you understand that, look at the list of the organisms that can be checked in a patient who has got pneumonia, and you have a specific sputum or a bowel or any of the respiratory specimen that comes to you. So you look for not only these number of bacteria, but you look also for atypical bacteria, which are very difficult to otherwise, get, especially Legionella, Mycoplasma, and Chlamydophila, and these are present in our scenario. We are not picking them up, that's why we do not know. Most of the times, I'm sure the clinicians are treating these patients with clarithromycin or any of the antibiotics which are specific for them. But if we have an evidence base, this pneumonia profile can give you an answer that yes, we are dealing with Legionella or we are dealing with Mycoplasma. So these are the bugs which are very difficult to cultivate and to find them or pinpoint them otherwise. Besides that, viruses, look at the number of viruses that you can look in a pneumonia profile, and of course, in a patient who is in a critical ICU, requiring critical care, in such patients can end up with multi-drug resistance. These are the markers that one can find, and appropriate management or treatment can be instituted at that particular moment. Okay? So this is what I mean by syndromic approach. You have one specific sample and you get multiple answers. Okay? Now, meningitis. This is where a sputum you can still get, gastrointestinal tract sample, you can still get a stool sample. Now, when I'm talking about GI panel, it is another panel which has got a great utility. When the sample comes for an investigation to the lab, stool samples are very difficult to get specific, pathogenic organisms in them. Because most of the time how the sample has been collected, there is a pre-analytical error, we might lose the specific bugs because of the overgrowth of the commensals. So here, if there is a GI panel testing done, you can look for not only the bacteria which have been overgrown by the other organisms, we can also look for parasites, which otherwise you require certain other tests to look for them. So these are the things that can be easily picked up by this testing. Now meningitis profile again is something where you can look for these organisms. As you can see, some of the organisms, some of the organisms are very difficult to grow. So they can be picked up, the viruses can be picked up, and even the fungi. The only grouse that I have here is that in an endemic country like India, tuberculosis could have been also added to this panel, and that would have just completed the whole picture for us. So that is something that I think all of microbiologists are in talk with the company, so they are looking towards adding that parameter as well. Then it would be a complete thing, otherwise the sample has to go for TB as well. So, and all these results are available in about 1.5 hours to 2 hours. That is the best thing. So you have one sample going to the lab, within 2 to 3 hours you have the answer, and then the clinician can institute the effective treatment accordingly. So coming to the nucleic acid amplification test, what are the applications that we can have for future? The first one that I would come across is fever profile. For fever profile, then sexually transmitted diseases and blood screening. So let me go one by one. Fever profile. Some 2-3 decades back, when a patient would come with fever with chills, the mind just goes in favor of malaria and maybe urinary tract infection. But today we have what came then enteric fever was added to it. Organisms having bizarre presentations. So even dengue, leptospira can have respiratory presentations. Same is the case. Just I think in September 21, there were clusters of chikungunya which happened all over the city. And here, chikungunya is known to cause meningitis, but last year there were cases of pneumonia as the presenting feature of chikungunya. One would have expected chikungunya the patient to come with arthralgia and fever, but here we actually saw patients coming with pneumonia. So in a scenario where the organisms having bizarre presentations, it is very important to come to a diagnosis faster. So here we have these diseases which can be detected if you pick up the sample or send the sample for nucleic acid testing or molecular testing, and you can look for malaria, dengue, chikungunya, salmonella, rickettsia and leptospira. Rickettsia is also on the rise at the moment, so there are cases of rickettsia happening. So all these parameters can be checked from one sample itself. Now, sexually transmitted diseases, look at this. This is the statistics of India, of the US. Unfortunately, I don't have the statistics of India. You can see that from 2013 to 2017, there has been almost 31% increase in sexually transmitted diseases. And similar 67% increase in gonorrhea, 76% increase in syphilis. So, and of course, chlamydia. So these are the diseases where the organisms are very difficult. If at all you try to culture them, they are very difficult to culture. Unless you are collecting the sample at the sex clinics and immediately culturing them, the maximum that you can grow is probably gonorrhea. But the other organisms are likely to be missed. So these organisms can be easily picked up by molecular diagnostics if they are subjected to these various panels. So sexually transmitted diseases are on the rise in our country also because of promiscuity, because of high risk behavior, multiple sexual partners, and also various sexual preferences. So definitely this is something which we have to keep ourselves ready for. We have to keep our eyes and ears open. One of the places where it has got a major utility is the donor screening, donor blood screening. Now look at this. You look for typically these three viruses, and conventional serology testing, the window period is 15, 38.3 and 58.3 days in cases of these viruses. This has been reduced to, 15 has been reduced to 4.7, and 38.3 has been reduced to 14.9, and 58.3 days of window period has been reduced to 2.2. So this has been all possible because of the molecular diagnostics testing. So here you can look for HIV, HBV, HCV, also syphilis and malaria, especially the ones where the blood, the donor blood, if it all screens, so that the transfusion-based infections can be prevented. Now, one more scary part that I would like to highlight here is that in spite of all our screening, still 2 persons out of 1,000 end up with HIV infection post-transfusion. Same way in case of hepatitis, 12 persons still end up with infections after transfusion out of 1,000, and the same way for hepatitis C, we have seen 4 persons still ending up with the infection. So this testing will definitely help us to reduce the numbers further. Besides this, there are some rising viruses, Nipah, Zika, rabies. So these are the viruses where prompt diagnosis will be of great help, and molecular diagnostics has also helped us in infection control practices, where isolation of such patients who can transmit the diseases to others can be instituted. And one more utility where we have found the use of molecular diagnostics is for HPV. There is enough evidence showing that HPV is associated with cervical cancer, and one can screen women from 25 years of age to 65 at regular intervals. We can pick up the disease, and the treatment can be instituted. So these are the automated NAT platforms which are present, and you can see that this is the BioFire machine that I was talking about, and it's just one cartridge, a small cartridge into which the sample can be loaded, and it is put into the machine, and the machine gives you a result within 1.5 hours to 2 hours. This is GeneXpert. Everybody knows about GeneXpert. So you have this cartridge where the sample is loaded, and it goes into the machine, and the machine again tells you the results in 1.5 hours to 2 hours. So life has become very, very convenient right now as far as the usage of molecular diagnostics is concerned in infectious diseases diagnosis. Now, this is the Make in India technology, and I'm very excited about this because this is something that we should all be proud of, that we have Indian-made technologies and they have great utilities. So this is MolBio's TrueNat. TrueNat has gained a lot of importance as far as COVID-19 is concerned, and they are coming up with many panels on their platform. Same is the case with MyLab. So these are the various Make in India technologies, and the space is definitely going to increase further, and we'll have more players in the market. So now the next is definitely one thing that I want to discuss is that not every individual who has got a critical illness ends up with the same kind of an outcome. We have seen in COVID that many patients who we suspected to come out beautifully had a downhill kind of a transition, and we have also seen patients whom we did not expect to do well doing better. So obviously there is something that is happening at the molecular or the genetic level. So this is where we'll be able to know the disease targets, and we can very well predict as to the outcome of the disease or what that particular person can end up having the disease. So that will lead to targeted therapy. So you know that this is the disease that the patient is definitely going to get in due course of time, and he can have a targeted therapy, and same we will have a tailor-made. So it will be every individual will have a treatment module which will be similar, which is made for him. So this is something which will happen in future. So watch this space for more to come in future. Now coming back to the slide where we were talking about how bizarre organisms having a bizarre presentation. So a simple E. coli which we would have reported maybe when we were student in a culture might not be a E. coli anymore. So we are in a stage where we are here, meaning when you have too much knowledge, you are confused as to what you are dealing with. So those answers are probably going to be given by molecular diagnostics. So thank you so much for your patient hearing.
Any questions?
There is something about PCR inhibitors.
So
because during COVID RT-PCR, they had a couple of cases where they got feedback from the lab that they are not able to give results because probably there are PCR inhibitors.
So there are especially nasopharyngeal swab when it is being collected. So if patients have taken some inhalations or something like that, they have hampered the usage of giving us the proper results. So these are something which is beyond. I mean, we can't because this is patient centric. Like, so we cannot really have any technology wherein we can remove the inhibitors. The only way that we can do it is by doing the collections properly and making the patients aware of it, that you have not done this, so we collect it. So these are the ones. It is very difficult to control that in the lab. It is difficult to control in the lab.
If this molecular technology is going to work so better, within 1.5 hours you are getting the reports.
That's right.
Do you think that this is going to replace all traditional tests? Because ICU patient with the septicemia, yes, one test and you have everything in your hand.
Not really, sir. We can't really say that because the organisms in molecular testing, I'll put it very simply in whatever way I can explain. Molecular testing, we are looking at one particular target, okay? But the organisms are undergoing mutations multiple times. So we are looking at one target which might give you one result, which might not be completely compliant to what the organism is. So there is a possibility that the mutations might happen which will be expressed better phenotypically. So what I'm trying to say is that we cannot get away with just molecular testings. They would be an adjunct or a good way of using them for our in combination with the culture methods as well as your clinical judgment.
Is it going to do, suppose if you do molecular test as a basic, then that can lead to the other specific tests, then you can move into the traditional one.
So, it cannot be the first method of testing. You will have to do the traditional test along with it, at the moment at least.
Because the way you said about the molecular testing.
I'm talking about molecular testing where we do not have the traditional methods as of now.
No,
for those, molecular testings will be a big help.
It will be a boon to the pathologist, no? And for the clinician also.
Yes, it would be. For the non-culturable ones.
Because most of the time those patients in ICU and say hospital-induced infection, there are a lot of problems getting in the reports also, and there is hardly any time in your hand to think about starting which antibiotic.
Absolutely.
In that case, it will be boon.
It will be. It is a boon. But it is a boon for sure. But we cannot undermine the importance of the traditional methods.
You are taking side of it. No problem.
Sir, I'm still in that.
But the machine you said, no, so it is easy to go into something like a artificial intelligence. You put in the test and within 1.5 hours or so, the machine will tell you the diagnosis. You don't have to use yours.
I'm in that threshold wherein I cannot completely rely on this. I'm still in that phase wherein I want everything.
Because it is said that anything that is new is first ridiculed.
Yeah.
then criticize, and then
Yes.
it is accepted.
Yes.
So by the time another 3
Yes.
or 5 years down the line,
Yes.
probably this will be the
Yes.
instrument which is required by all the pathologists.
Yes.
Is it?
Yes.
Thank you.
Now, many false positive case pick up in a vaccinated patient, and if it picks up the common cells, then how to go about it?
Sorry? You mean to say COVID-19?
No. Any vaccinated patient, can this molecular
like the
testing-
dead organisms, yeah.
Can it pick up the positive results?
It can. We have seen, like for example, even COVID-19, we have picked up, so when you are picking up the organism, you have to make sure that are you dealing with the presence of the organism or the disease of the organism. So that is something that can be done clinically. So in a lab, when we pick up the organism, we will tell you that we have picked up the organism. So there has to be a correlation, a clinical correlation. Even in COVID-19, what we have seen is that patients have got infected, but not necessarily had got the disease. So we have picked up the organism and they have shed also immediately, meaning there has been a shedding of the viruses. So these are something where the clinical correlation is important.
Madam, can it pick up the common cells where we don't have to actually treat the patient but the test?
Yes, it might. Depending, so that's what I'm saying. So there you will have to do the clinical correlation. Even for that matter, in this syndromic approach, we have seen, initially we used to see multiple organisms picked up. But then we also realized that there were cases where these multiple organisms were significant. They were causing the infection. So we cannot undermine, we cannot just shrug away the report saying that, this one is showing me all the pathogens. There has to be a correlation, there has to be a clinical, look into the case, and it has to be fallen back on. Thank you.
Hello.
RT-PCR report of COVID. We go by CT value as well. Your comment about CT value. Suppose CT value is high, it comes to 30. Should we take it as a negative? And second, can we do RT-PCR for mycobacteria in mosquito? What is the minimum load of bacteria to come this as a positive?
Okay.
RT-PCR to come positive.
Okay. So your first question, sir. Actually, CT value is cycle threshold, and it is a test. Unfortunately, it has been given a lot of importance throughout. But actually, the CT value is a test that is significant for a lab personnel. So every day when we put up the cycles, or rather we put up the test, the cycle threshold, the threshold where we are detecting the organism may vary every day. Okay, but unfortunately, yes, it is true that the number of viral, or rather number of organisms that are present, their CT, they will be picked up. So there is what happens is PCR is polymerase chain reaction. So there are multiple cycles that the test runs. Okay, if the organisms are in good amount, they will be picked up in the early cycles. That's why your CT value is lesser. Okay, if that is lesser, then the cycles taken to pick it up becomes higher. So that's why your CT value goes higher, in simply put. But again, the CT value changes every day for me. My cycle today I would find that at 24 also I am picking up lower volume of viruses. Tomorrow I would see that 30 is picking up lower volumes. You get me, sir? This is as far as the conventional PCR that I am talking. So it cannot be an indicator of the 24. So it is a daily change. It changes daily. But yes, lower values, lower CT value has been, you can corroborate roughly, not really in a very accurate way, that this could be a major viral load or a better viral load as compared to a higher CT value. That's one. The second question, sir, was regarding the load of the bacteria, right?
So every system has got a sensitivity, like about in a gene expert or a Cepheid machine, about 100 bacilli has to be present for it to be detected. And for in case of again it depends upon the specimen, how the specimen has been collected. If it has got a high volume of organisms, then it will show a higher load. So actually it is based on the amount of organisms that is present in the specimen. So if you pick up in a gene expert, it will pick up in 100 bacilli will be also picked up, whereas in a TrueNat, 4 into 100 bacilli is the minimum bacilli required to pick up. So there is a variation. Yeah, sure.
That should be remembered by all of us. The CT value has absolutely no correlation to severity of infection. All that it can tell you is probably the genomic material of the virus, not even the live virus, but the genomic material of the virus. It could be live, it could be dead. Early in the infection, it is usually live, but what studies have shown is that the typical COVID infection after day 8, the virus is dead. So post day 8, you will have viral genomes present in the throat, and that can be picked up by your PCR. That's one of the drawbacks of a PCR, but PCR is that, meaning this technology works like this. So it has no correlation with clinical severity. It has all that you can possibly say is, okay, whether it's beyond 8 days, so isolation precautions, we would use it for isolation precautions. If you want to remove a patient from an isolation setting, your CT value might actually help you. Or if you want to admit a patient into a hospital, do a procedure, and you want to understand whether this would be infectious, non-infectious, probably that is the way that we are today interpreting the CT value. So anything beyond 30, we possibly would say that it is non-infectious. And in fact, according to ICMR at CT 35, I believe we are also reporting as negative.
Yeah, we are reporting as negative. Yes. So again, in TrueNat, up to 32 CT value is reported as positive, and beyond that is reported as negative. But now today's guidelines is that beyond 30, try to take it with a pinch of salt. Probably it was negative.
Thank you all. Any questions can be asked after during lunch time. Thank you, madam.
Thank you.
I'll call Dr. Ajay Shah, sir, to felicitate madam.
I will call Dr. Aruna Pujari. She is a senior microbiologist in charge of British Candy Hospital and my very old friend.
Thank you, ma'am, for that excellent molecular diagnostics talk. For the next talk, we have our with us eminent interventional cardiologist amongst us, Dr. Bhavesh Wajibdar sir. Sir has completed his MBBS and MD from State GS Medical College in KM Hospital, and then he has pursued DNB in cardiology from the same institute. Sir has also done multiple fellowships from across the globe. He is also a member and fellow of various cardiology societies like Cardiological Society of India, American College of Cardiology, European Society of Cardiology. Sir has almost 22 publications to his name in International Index Journal. He also has 33 abstract papers in Indian Heart Journal. Sir has performed thousands of interventional cardiology procedures to date. He is currently practicing as cardiologist, a consultant and interventional cardiologist at Lilavati Hospital, Holy Family Hospital, as well as Karuna Hospital. He also has his own clinic by the name Meena Heart Clinic at Thakur Village, Kandivali East. Today, Sir will be enlightening us about the role of cardiac biomarkers and their value in risk assessment of coronary artery disease. I welcome Dr. Bhavishri Darshan.
Good morning, everybody. First of all, thank you so much for this kind words, and a special thanks to Dr. Ajay Shah for this opportunity to interact with so many of our colleagues. I think over the last couple of years we have lost touch with each other, and it's really nice to see all of you. Some of you, I think I'm seeing after quite a long time. So thank you, and it's really nice. Moving on to the topic of biomarkers, again a very extensive topic. I'll try to do some justice with some clinical implications in a short time what we have. To start with the definition, what is a biomarker? There are numerous complex definitions for biomarkers, but this is something simple. It's a molecule which can be found in the blood, tissue, or any body fluid, and it should be a sign for a normal or abnormal process, and it could be giving us a prognosis and diagnosis of any condition or its treatment. A cardiac biomarker. Now, what is a cardiac biomarker? So these are substances that are released into the blood, and when the heart cell or the heart muscle myocardium is damaged or stressed, the commonest cause is ischemia. It could be infection. It could be just a mechanical stretch, but the commonest is ischemia. And the measurements of these biomarkers helps us in treat these patients with cardiac disease better. They help not only in the diagnosis and the prognosis, but also we can judge the progress of the disease and how effective our treatment is, and then we can guide the patients better. So there are a lot of cardiac biomarkers, and I think this is just a short list of some of the things which you know. Earlier we were using things like SGPT, LDH. We've given up all those things. Myoglobin was used for some time but has a lot of fallacies. D-dimer and PCTs, of course, as coexistent to look at coexisting diseases like thrombotic disease or infective disease. CPK-MB, yes, still we use it quite often, and we know that it's a very good tool. The limitation being that it is active for a short while, and hence there is a little drawback there. HSCRP, about 15 years back, there was a big talk about HSCRP being able to diagnose who is going to have an MI, who is going to get an acute coronary syndrome. I think there were some very large papers and studies by Dr. Paul Ritker, who brought in this concept of HSCRP for the diagnosis and for the prognosis of patients with coronary artery disease. However, it has had some value. I won't say that it is of no use. It is of some use, but it is not a very clear-cut marker for the diagnosis of coronary disease or for acute coronary syndromes. So it is useful when, as a marker, it is not a direct agent which should be relied on for the diagnosis. It can help in addition to so many other factors. ST2, not many of you may have heard. It's a marker for tissue fibrosis, and usually it is seen that people with high ST2 go into a worse stage if they have any heart disease, especially heart failure. Not really very commonly used worldwide and in our country too. But these are the last two ones, the troponin and BNP. I think these are the ones which are widely used, most helpful to us, all of us, to the clinician sitting in the dispensary. to the intensivist in the hospital, in the ICU, and if you are in your consulting room or wherever. So these are the two biomarkers which are really prevalent, and I thought we should be discussing these in today's lecture. And these two markers are going to show us what we can do or what is wrong and how we can approach patients with either ischemic heart disease or heart failure. So let us try and see what we can do. The most difficult thing in treatment of ischemic heart disease is trying to pick up a patient whether he truly has cardiac pain or not. I think it's easier once you have an angio done, and to do an angioplasty is fairly straightforward. But if you are a general practitioner or a physician sitting in your consulting room and a patient comes with a history of chest pain, to decide whether it is ischemic or not, whether it's a coronary disease or not, is quite a task, and we all know that. So we rely on all these things for our diagnosis. The most important thing which I think is necessary is the history, because we all know we should be taking the characteristics of the chest pain, where is the localization, what are the aggravating factors, and so on and so forth. I think the history is really very, very important. Physical examination, yes, there are some things like, tachycardia or bradycardia, and maybe sometimes the local tenderness can tell us it's just a costochondritis. But history is probably more important than physical examination. ECG, yes, quite an important tool, but all of us as general practitioners or physicians may not have direct access to ECGs at that given moment of time. And also, we all know that it's really very difficult to read an ECG. Even as a cardiologist with so many years of experience, there are times when we do not know whether this ECG is truly showing, ischemia or infarct or not. We all know that. So this has its limitations. Echo, of course, a little bit ahead than ECG, a little more accurate. But then again, the availability is a problem. Not every patient who comes with chest pain, you can put an echo. Yes, if you are a cardiologist with an echo machine in your consulting room, you can do that, but a vast majority cannot. And then we come to cardiac biomarkers, and yes, relatively standard. Nowadays available across most of the pathology labs and easily accessible. Not really very expensive. Most of the labs are ready to give the reports in an hour or two, and we can really rely on this for our diagnosis. It's not observer dependent. So these are some of the causes of chest pain. I thought we'll go a little bit away from just the lab, some clinical things for us. So we all know that a chest pain is a syndrome because of multiple causes, and it could be acute myocardial infarction, myocardial ischemia, myocarditis, pericarditis, so many cardiac causes. Then there could be non-cardiac causes, the commonest being pulmonary, GI, and skeletal. In pulmonary, you could have a pulmonary infarction, pulmonary embolism, pleuritis, pneumonia can all cause chest pains. You can have orthopedic causes, very common, most common muscle injury, inflammation, costochondritis, cervical and rib problems, and gastrointestinal problems. We all know these are very, very common, and these are some of the rare causes: aortic dissection, aneurysms, anemia, sickle cell disease, crisis, so on and so forth. So there is a huge quantum of differential diagnosis. Patient comes to us with chest pain, and it's really very important for us to differentiate them into two broad categories and then further down. So first you have to decide whether it's a cardiac or a non-cardiac pain, and for that we use our various investigational modalities. And once you say that it is cardiac, then again you decide whether it's a chronic stable angina patient or it's something with an acute coronary syndrome. So why is it very important for us to differentiate the different types of coronary artery presentations? And this is an illustration. I'm sure all of you have seen this before, but I think this is the basis for the treatment and management strategies which we employ for our patients with coronary disease. And we should all know that the artery is normal when we are born. Which is the pointer. Yeah. So you could have, this is a section of the coronary artery, a schematic presentation, and you know that the plaque starts with cholesterol deposition in the intimate media, and then slowly it grows over time, and then starts, impinging onto the lumen. But this takes not just days or months, but it takes years and sometimes decades to progress. So if you have something which goes on like this, it can of course produce symptoms from this stage and ahead, but usually it can only cause angina. It doesn't cause a mortality or morbidity or an infarction. However, if this plaque becomes unstable because of many reasons, the commonest being any physical or emotional stress or so many other things, then the lipid content of the plaque comes out into the lumen of the coronary, and that causes an acute thrombosis. So this acute thrombosis can occlude the vessel completely or partially, and this can take a few minutes or few hours to present. And a patient who has been completely stable, he could be at this stage or at this stage, he is stable, but once he develops a plaque rupture and a thrombosis, then that is when he becomes unstable. And this is the point where you get a maximum number of mortality and morbidity. So that is why it is important for us to differentiate whether the patient is in acute coronary syndrome stage or in a chronic stage. This also is a diagram I'm sure all of you have seen, which says that if you have a person who has no symptoms, then the 1 year mortality may be just 1% or less. If a person has severe coronary artery disease but is stable, then the mortality may increase to only 2% at the end of 1 year. But if you look at patients who are presented with an acute coronary syndrome, let it be an acute myocardial infarction or a non-ST elevation MI or just an acute coronary syndrome with high troponin, then the mortality is 8-fold. The 1 year mortality is almost 15%. So that is the difference, and that is why we should, as clinicians, be able to differentiate between a stable angina patient and an unstable patient. So for doing that, the commonest thing which we rely on is a cardiac biomarker. And I'm sure again all of you have seen this diagram before. This is the duration in days 1, 2, 3, 4, 5 from the onset of pain. So this is the onset of pain here, and this is the duration of time, and these are the levels of the various enzymes which we see, which are secreted by the myocardial cell during ischemia. And here you see the earliest to rise are these myoglobins, but unfortunately they drop also very quickly, and they are not really of good diagnostic importance or rather relevance. Then we have CKMB, which again rises within a few hours, peaks by about 1 hour, 1 day, and starts dropping beyond 2 days. It's hardly of any use. Troponin, on the other hand, troponin I or troponin T, has a peak which starts early, and the peak sustains for a time, and as long as almost 5 days we can use, we can detect troponin elevation if the patient has had an acute coronary syndrome. So in all patients who come to us with symptoms which are like an acute coronary syndrome, we are supposed to do cardiac specific troponin tests, and this could be either I or T. Some labs do both, some labs do only I, some labs do only T. I'm not in the position to decide why it is happening. Probably Dr. Ajay Shah will tell us. But we can use any of them, and nowadays we have a high sensitivity troponin which we are doing. Earlier we were using the regular troponin. Most of us have switched to high sensitivity troponin, and the beauty of the high sensitivity troponin is that we can pick up the patients much earlier. So most of the times within 3 hours from the onset of chest pain, if it is acute coronary syndrome, then the troponin will be elevated. So at 3 hours from the onset of pain, if you do an HS tropa and if the troponin is not elevated, unlikely, I'm not saying not, but unlikely to be acute coronary syndrome. If you are using a regular cardiac troponin, then that window period is up to 6 hours. So it's important for us to do at least 2 samples, one at presentation and one after 3 to 6 hours, depending on what troponin you are doing. And then you identify whether there is a change in the pattern. Sometimes you may see that the troponin is increasing, but if you are seeing the patient sometime away from the myocardial damage or injury, then you may even see that the troponin is actually falling. So a rise or a fall, whatever it is, if there is a significant change in the troponin level, then it indicates acute coronary syndromes. So again, to emphasize, as of now, one single sample of troponin may not be absolutely sensitive and specific for ruling in or ruling out acute coronary syndromes. We are supposed to do at least 2 tests, one at the time of presentation and the other 3 to 6 hours after presentation. So that is, when if both are negative, then it's highly unlikely that this patient has acute coronary syndrome. But what if the troponin is high? Does it mean all patients who have high troponins have an acute coronary syndrome? The answer is definitely no. And this is where I want all of you to understand, because my previous speaker, Dr. Rupa, emphasized so nicely that whatever test you do, you need to have a clinical background. You need to take the clinical situation into consideration. So similarly, if a troponin is elevated, don't just jump onto the diagnosis of acute coronary syndrome. Always, you should have the history, you should have the symptoms, you should have the ECG changes, echo changes, and also the troponin. So if there is something different, then be very wary. There could be a false positive troponin elevation, like so many conditions. So you could have the commonest things, renal dysfunction, acute or chronic, congestive heart failure, even severe hypertension can raise the troponin by causing subendocardial ischemia. If you have a arrhythmia, either a SVT or a VT, or sometimes even a severe bradycardia can cause arrhythmias. Things like pulmonary embolism, severe pulmonary hypertension, inflammatory conditions like myocarditis, neurological conditions also, aortic dissections, aortic valve disease, hypertrophic cardiomyopathy, again causing subendocardial ischemia. If you have a cardiac damage because of an intervention, like if you're doing a radiofrequency ablation for an arrhythmia, or if you're put in a pacemaker and the pacing lead is hitting the myocardium, when you have done a DC cardioversion for a tachycardia, if you have taken a biopsy, then all these things can increase your troponins. Of course, then there is this Takotsubo syndrome. This is a recently diagnosed, recently found syndrome, I think, but almost a decade now, where you see the patient presents with an acute anterior myocardial infarction, has a severe tachycardia, hypertension, so on and so forth, and classical presentation of infarct, but the coronary artery is normal and usually caused by a catecholamine surge, more common in younger women. Then still further, so many sarcoid which is infiltrating into the heart, you will get troponin elevation, sometimes drug toxicity, especially anti-malignancy drugs, and then also things like burns, rhabdomyolysis, and critically ill patients if they have severe sepsis and so on and so forth. So the list is so huge. We need to understand that we have to take the cardiac biomarker or troponin or CKMB or whatever it may be in collaboration with our clinical situation. Just don't rely on one thing. Just a minute or two on the management strategies for acute coronary syndromes. For acute myocardial infarction, I think everyone knows that early primary angioplasty to open up the artery is the best. And if you can't do it, then you thrombolize and then you send the patient for an angio and an angioplasty. Similarly, for patients with acute coronary syndrome also, there is a very strong role for invasive therapy. And if you have a patient who is very unstable, so there is no ST elevation MI, just an acute coronary syndrome with ST depression. But if the patient has some very critical signs like a refractory angina, worsening mitral regurgitation, hemodynamic instability, sustained VTVF, so on and so forth, then this patient has to be sent to the cath lab for immediate revascularization within 2 hours. So almost treat these patients like a patient with acute myocardial infarction. If you have a patient which is not that bad, then it comes to still you need to send the patient to the cath lab within a day. And if you have a very low risk patient, then you decide if the patient is very stable, you may not send the patient for a cath angio, but evaluate further with a stress test or thallium or something like that. So there is a clear-cut evidence with many trials which show that if you have an early invasive therapy, that means if you have a patient with acute coronary syndrome, if you send them for an early angio and an early revascularization, you are definitely going to reduce the all-cause mortality. You have a reduction in all-cause mortality, you are going to reduce non-fatal myocardial infarctions, and you are going to reduce recurrent hospitalization. So all patients who have a high risk acute coronary syndrome need to go for an early intervention. Like this gentleman who was 86-year-old and presented with some discomfort. He was not even able to tell us. He was a healthy 86-year-old and he just presented with some discomfort in the chest, mild breathlessness, nothing much. ECG not very classical, but the enzymes came positive. The echo showed hypokinesia in the LAD territory, and he had a significant coronary artery disease, and we had to do what we call a rotablation, followed by stenting, and then we could, visualize the stent. This is an OCT being done for this guy to see that the stent placement is good, and the patient did well. Even at 86, he did well. This is for almost 2 years, and unfortunately last year we lost him to COVID. So this could not have been possible if we had no cardiac biomarker. If the troponin would not have been done at that age with DIC symptoms, we would not have taken the patient for an angio. So these are some of the benefits of using troponin. Now recently there is also a talk of trying to identify patients earlier to try and get more and more patients triaged with troponin to increase their threshold for interventional therapy and so on and so forth for better outcomes. So with that, there are some recent papers. There is one paper last year says that a single value of high sensitivity cardiac troponin T at 1 hour, if it is less than 6, so 6 is really a very low threshold. Most of the time we accept a threshold for men at 30, 35, like that. So this is a really low threshold, but if what they say is if it's lesser than 6, then one single value is also enough. Of course, this is a new concept. It's still not into the guidelines, and still we need to rely on 2 samples as of now. Maybe later on it becomes a strategy. Also, troponin is now being used to identify people who are at high risk, who are otherwise normal. Like for example, this study. So they studied some patients who had mild hypertension. They really had mild hypertension and they had no coronary artery disease. If they had coronary artery disease, then they were excluded. So mild hypertension, not even on therapy. So it was so mild that you were just on stage 1, not on medications. And even when they analyzed, they took TNT and NT-proBNP samples for all of them, and they found that a lot of them, 22% had high TNT more than 6, that was their definition, and 18% had high NT-proBNP more than 100. Of course, these are very strict criteria by all standards. And when they followed them up for 10 years, 10 years is a long period of time, they found that for the people who had those higher biomarkers, the incidence of cardiovascular events was 11% at 10 years as opposed to only 4.6% with the low biomarker level. But what does it imply? We really don't know. I don't think at this present date and time we are justified in doing say NT-proBNP or troponin I for everybody just to prognosticate what is going to happen later. But it's an interesting concept. Maybe in the future it comes, we don't know. Then moving on to the next thing about the NT-proBNP in heart failure. We all know that heart failure is not a disease but a syndrome. It's the end point of many diseases, and it is we know the definition. It is a state in which the heart cannot supply enough blood to the body, or can do so only with a lot of stress and strain. So that's a simple definition for heart failure, and the cause for heart failure could be so many. The commonest being myocardial causes following a myocardial ischemia or myocardial infarction and LV dysfunction, but it could be pericardial disease, valvular disease, endocardial disease, and so on and so forth. And then we also have a concept where the left ventricular ejection fraction is normal. So classically, when somebody says this patient has heart failure, we think that the left ventricular function is poor. But then there is a subset of patients who are symptomatic despite their ejection fraction being normal or hypernormal. And these are the patients with hypertrophied heart. And the problem does not lie in their systolic contraction but in the diastolic relaxation. Because of the thick wall, the relaxation of the ventricular muscle is affected, and the diastolic pressures go high. When the LV diastolic pressure is high, it transmits to the left atrium and then onto the pulmonary circulation, and the pulmonary venous pressure goes high and the patient becomes dyspneic and has dyspnea. So these are again a new concept of diastolic heart failure. There are a large number of patients with heart failure, we all know that, but we need to understand that in India, younger patients are getting heart failure. So the mean age of presentation for heart failure globally is 73, in India only 53. So that difference, younger patients, and look at the mortality, in-hospital mortality, 3.8% versus 30%, 10 times. Probably because we are admitting the patient later stage. We are not admitting them earlier. And also, there's a high mortality in hospital and after discharge also. Again, a very classical, diagram which all of you know about the prognosis in patients with heart failure. Once you detect heart failure, it's always going down towards death. The patient may be stable for some time, then get severe decompensation, gets admitted or treated, improves, but never comes back to the original condition, goes down, and then again next, and so on and so forth, and once ultimately will succumb to heart failure. The 5-year mortality for heart failure is worse than most of the cancers. It's really very bad, and almost 50% of the patients with heart failure are dead within 5 years. And not only that, even people who are less symptomatic. So sometimes we say that when the patient has a very mild symptoms, class 2 or class 1, that means hardly any symptoms. But if he has heart failure, 1/3 of them are going to die within 3 years. So really very important for us to pick up these patients, because these are going to be very mildly symptomatic and many a times we won't pick them up. And here's where the NT-proBNP comes into play. It's really very difficult to pick up heart failure clinically. We all know this, all the symptoms and signs of heart failure. However, we know that also there are many conditions which will mimic heart failure. So you could get dyspneic because of asthma or COPD or lung disease. You could have edema feet because of liver or kidney disease. You could be coughing because of asthma, bronchitis, and so on and so forth. So it's really very difficult to clinically pick up heart failure at lots of time. In fact, yesterday I have seen a patient, one of our pediatrician's mother, 70-year-old lady, and was presenting with just chronic cough and little dyspnea, and for almost 1 month going around here and there with a diagnosis of URTI, LRTI, asthma and so on and so forth, but found to have severe LV dysfunction and NT-proBNP which was high. So it's really very difficult. That patient was seen by at least 3 physicians, and patient saw himself as a pediatrician. So the idea is to say that when you are sitting in the consulting room, it's really difficult to pick up exactly what is the cause of that dyspnea. So what do? So you rely on these tests. So what are the tests which you can do? You can do an ECG, but an ECG of course not very, very specific. X-ray does pick up pulmonary congestion, but it's quite late by the time you pick it up. You can do an echo, I think that's the standard thing, and then you can use biomarkers, which is NT-proBNP. So not going into the details, but this is the natriuretic peptides are secreted by the atrium or the ventricular cells when they are mechanically stretched, and when these are secreted, they have a host of good effects to counter the heart failure. But however, we are using these to, as a indicator for heart failure. So we can use natriuretic peptides or BNPs for diagnosis of heart failure, and this is the from the, I think this is the American College of Cardiology guidelines, and gives the values for BNP and NT-proBNP. So one more important thing which I want to tell you, that nowadays all of us are using the new drug for heart failure, which is called ARNI, or nebulized. This is angiotensin receptor inhibitor plus nebulizing inhibitor. It's a combination sacubitril valsartan, commonly known as Vimata or Sidbus. Now there are so many other generic options also available. So that drug affects the BNP, so it does not truly let the BNP reflect the true status of heart failure. So nowadays we should avoid using BNP for diagnosis of heart failure. Use only NT-proBNP, because many of our patients will be on the new drug, that is ARNI. So use NT-proBNP. If your NT-proBNP less than 300, it is unlikely to be heart failure. More than 900 is likely to be the heart failure, and in between is an uncertain diagnosis. Elevated NT-proBNP not only tells us the diagnosis but also tells us the prognosis. The higher the values of the NT-proBNP or BNP, the worse is the outcome in terms of mortality and morbidity, repeat hospitalizations. And not only that, it helps us in getting a prognostication. That means if you have a patient who has come with a high BNP value, and if you start treatment and after a few days the BNP value comes down, then you know that this patient is improving. Similarly, if it worsens, if it goes higher, then that means the patient is worsening. So you can, adjust your medications according to the trend of BNP. This can be used not only in the hospital, in the ICU, but also it can be used in the outpatient department. If the patient sees you today and then sees you after 1 month, if you see that the NT-proBNP has risen, then you know that the therapy is not effective and you need to tighten it up. I think there are a lot of pitfalls for BNP. They are falsely elevated in many other conditions, so please be very aware. And again, this is a list of the false elevation of BNP without heart failure. So besides heart failure, it could be elevated with heart muscle disease, acute coronary syndrome, atrial fibrillation, common valvular heart disease, cardioversion, so on and so forth, and so many non-cardiac conditions, advancing age, illness, critical illness, anemia, sepsis, renal failure, burns, pulmonary disease, so many things. So we need to understand again that this is not just a heart failure, it could be so many other causes for NT-proBNP elevation. I think I will stop my lecture here. There's going to be so many other things, but it's going to be shooting over the time. I can answer questions if there are any. Okay, so it depends. Usually it's 4 to 5 days at least. If the patient is in the ICU, if in the outpatient, then maybe a month or so, but definitely not before 2 weeks. So if you are seeing the patient in the outpatient or in the clinic, then there's no point in doing after a week or two, because the patient is going to be stable. You are looking at long-term effects of that therapy. The earliest you should do at 2 weeks. or maybe a month or so, but not less than 2 weeks. But in the hospital setting, you can, if the patient is very critical, you can repeat it after 4 or 5 days.
And the pro-BNP will be based upon the age also?
Yes.
So, mildly elevated pro-BNP in 80 years will be normal?
Yes, so very clearly most of the good labs will give us the reference values for anti-pro-BNP or BNP as per age also. So you will see many times the reports say that if your patient is above, so normal values of anti-pro-BNP less than 300, but if your patient is say 75 or so above, then almost 500, 700. And we see that patients who are more than 80, even values of around 1000, 1200, something like that, without patient being actually in heart failure. Yes, but if you have a value which is say 3000 or 5000, then definitely it's not age related.
So you have not covered the treatment, but still, if we have to choose between a diuretic and a ARNI,
Okay.
if the BP is not permitted, so how we do?
Alright, so where is it? Sorry, can you put the slide on? So a diuretic is a symptomatic treatment for heart failure. Just remember, so use diuretics only when the patient is fluid overloaded. So if the patient comes with pulmonary edema or severe ankle edema or edema, so anyway, you know that he is congested, then use diuretics. Then of course the first thing is diuretics. But if the patient is not in acute pulmonary congestion or acute volume overload, please do not use diuretics. The patient may have an EF of 10%, 15%, but if he is not fluid overload, no diuretic. The drugs which are going to improve the outcomes of this patient, that means the drugs which are going to reduce the mortality, the drugs which are going to improve, reduce the hospitalization, improve the symptoms are beta blockers, ACE inhibitors and ARBs, and now the newer ARB, what we can call, it's actually ARNI, that is Vimada or Stridmus, the sacubitril valsartan combination. I think that should be the first drug to be started as long as the patient is not in an acute decompensated stage. Nowadays we are trying to start also in acute decompensated patients. We try to add ARNI, but so far as the guidelines say, only after the patient stabilizes we add that. But otherwise, yes, this is how the rule goes. The other drug which is also very useful is MRA or mineralocorticoid receptor agonist, that is aldactone, that is spironolactone or aplinarone. These are also drugs. So basic, I don't know if I have time, but the basic way to treat a heart failure is to treat the two axis which cause worsening of the symptom. One is the adrenal axis, and that is the renin-angiotensin axis, and another is the sympathetic axis. So for the sympathetic system, you use beta blockers, and for the RAS blockade, you use ARNI. Otherwise, you used to use ACE inhibitors or ARB and MRAs.
Comes with fluid overload, and we start him on diuretic, and then he stabilizes. So then we can shift him to ARNI.
No, so you can add, once he is stable, you need not, you can add. So
if the BP is not permitted.
Oh, if the BP is not permitting, then of course, then you first. Most of the time you will see that if the patient is fluid overloaded and if the BP is say 90 or 100, patients with EF of 10, 15, 20% are used to that BP of 90, 100. So even a patient BP of 90 or 100, patient is perfusing well. He has good cerebral perfusion. He is conscious and well oriented. He's got a good urine output. Then you know that that blood pressure is enough for him. And not only that, if you give him diuretics, you are not going to drop down. He's going to, all the third space fluid which is there is going to come back into the vascular system, and it's going to compensate for the fluid loss. So if you have a low blood pressure, unless the patient is in cardiogenic shock, that's a different story. But if you have a low blood pressure in a volume overloaded patient, if the patient is admitted, don't worry. Most of the times he's not going to have hypertension. If you have, then of course dopamine, NORAD and all that, that's different.
Is all about the outpatient.
Outpatient, if you have even a BP of 90, 100, if the patient is not symptomatic, as I showed, two important things, cerebral perfusion, renal perfusion, means good urine output, good mentation, that means he's doing well, you can give diuretics. or for that matter, vasodilators also.
So you can't stop diabetic, what I mean to ask. Is there a conscious shift from a diabetic to
No, shifting, as I told you, if you are fluid overloaded, you have to use a diuretic. There is no other question. So these are all not one after the other, they have different mechanisms. So the mechanism of action for diuretics is reducing the volumes, while the mechanism of action of beta blocker is to bringing down the sympathetic overdrive. And for the Vimada or the Setmus, it is acting on the RAS system.
Falsely low anti-proBNP in a flying heart failure, any condition of that sort?
Well, I really don't have any knowledge about where you have a falsely low anti-proBNP in this. I have no idea. Maybe Dr.Ajay Shah or somebody can shed light on it. No idea.
When you are using beta blocker, do you have the target to maintain heart rate at 60 plus minus? Or ARNI which has been proved to be good?
So the use of drugs like beta blocker and the ARNI-ACE or ARB is to reduce the mortality. It is not to reduce the blood pressure. I mean, the primary aim. Of course, the surrogate endpoints are there, but the primary aim is to reduce the mortality, and the benefits are a little more than just on what is on the heart rate and the blood pressure. So, if the patient is tolerating the drug well, then try to go as high as possible. You can start by up-titrating either one of the RAS things, ARNI or ARB, and then up-titrate beta blocker. As long as the heart rate and BP is fair, doesn't trouble the patient. There is no thing like 60 or 50, but I think if the patient is not really very symptomatic, then even 50, a resting heart rate of 50, I'm talking about resting heart rate, not exercise heart. Resting heart rate of 50 should be fair enough as a target for beta blocker therapy.
Because before the ARNI came in, they used to advise metoprolol that can increase right from 12.5 to up to 200 get suggested.
Yes.
To maintain the heart rate.
Yes.
So now since the ARNI is better over that.
No, still we try to go maximum dose for both beta blocker also and for ARNI. It's not that you give only one at high dose and another low. We try to increase both because both are known to reduce mortality. There is very clear-cut evidence across all spectrums of heart rate, across all spectrums of blood pressures of the patient. So in fact, there are graphs where, of course, this is beyond our lecture. But if you have a blood pressure of 130, or you have a blood pressure of 150, or if you have a heart rate of 80, or you have a heart rate of 70, if you start them on beta blockers and you reduce their BP or heart rate, you are going to benefit the patient.
So the titration of the dose is as per the heart rate and the BP? Or
heart rate and BP, as long as they are not falling, you keep on up titrating. If they fall, then of course, then you are. If they are symptomatically falling, then you don't up titrate. But suppose you have a heart rate of 60. Suppose you have put in your mind, I want 60 and a BP of 120. If you achieve that, doesn't mean you have to stop up titrating. If the patient can tolerate, you try to bring it up.
Thank you, sir.
Thank you, Dr. Bhavesh, for the enlightening talk on cardiac biomarkers.
Thank you.
I now call upon Dr. Ajay Shah to felicitate Dr. Bhavesh.
Call Dr. S.H. Doshi, senior most physician and our teacher.
Our next in line star guest for the day is one of our Neuberg family member, a doctorate in the field of reproductive science from the esteemed National Institute of Occupational Health, Dr. Shiva Murarka, who heads the Genomic Reproductive Department at Neuberg Center of Genomic Medicine. Holding such a responsible position speaks volumes about a passion for research and development in a field of expertise. A strong backing of multiple national and international research publications and chapters, coupled to a credit with a strong working experience of nearly a decade, justifies her position as a senior scientist. I, on behalf of all present here, welcome and request this young dynamic research scientist to enlighten us our knowledge of a relatively less discussed but yet important topic of non-invasive prenatal testing. I welcome Dr. Shiva.
Thank you so much for your words. I would like to thank Dr. Ajay Shah, Dr. Sagar Shah for inviting me to present non-invasive prenatal screening test. But before directly going ahead to present this, I would like to introduce our Neuberg Center for Genomic Medicine. So basically our center is into high-end genomic testing solutions, which has its base not only in India but globally, with the presence in Dubai, US and South Africa. We are the first one to house Illumina NovaSeq platform in the private laboratory. Now, we are working into sub-specializations in genomics like reproductive genomics, in which we are doing non-invasive prenatal testing, pre-implantation genetic testing like in embryo biopsy, endometrial receptivity test. Second, we are also into solid tumor testing like lung cancer, colon cancer. So we have like more than 152 gene panel. So if any mutation is detected, the patient can be benefited with the targeted therapy that are being available. We are also into hematology sections, plus immunotransplant sections. We have our huge base of immunotransplant HLA typing center in Chennai. Not only this, in addition to this, we are also into research based sequencing, in which the latest COVID genome sequencing is one such example, in which we were among the first 5 private laboratories which were supported by Indian government and into COVID genome sequencing. Now, after having an amazing lecture series into hemat, molecular microbiology and cardiac, I would like to take you to the genomic testing, that is non-invasive prenatal screening test. Chrome. This is our brand name for non-invasive prenatal screening test. Now before that, what is this test for? This is for aneuploidy screening. And why this aneuploidy screening is so important? So considering the aneuploidy prevalence among the general population, if you see trisomy 21, the frequency is 1 in 700 live births, plus trisomy 13 and 18. But this test is more important for trisomy 21 because we have ultrasound markers available for trisomy 13 and 18. But for 21, yes, this plays a very important role and it has a high sensitivity and specificity. Now, as we all know, this risk of Down syndrome basically increases with age, that is maternal age. Now, as this slide shows that there is a risk of 1 in 2000 if the maternal age is around 20 years. It increases to 1 in 100 with 30 years of female. It again increases in 1 in 100 with the female aged 40 years. That means no age is risk free. And it is the commonest genetic cause of intellectual disability. And as per the recent ACOG and ACMG guidelines, it is very important to offer the screening testing solution to all pregnant females. Considering the history of Down syndrome screening, it was back in 1980 when amniocentesis was actually came into existence. Later on, there were further screening, biochemical screening markers, first trimester screening markers came into existence. It was in 2015 when NIPT actually takes a seat. These are the screening testing options available, like biochemical markers. They are available from as early as week 10, 15. But the problem is they have sensitivity ranging from 60 to 85%. That means more number of female will undergo invasive testing. Now the big question, do we have a test with better detection rates, more accuracy, and it is safe? Yes. CHROME, that is non-invasive prenatal screening test. Now what is this test basically? So when during a pregnancy, what happens is a cell-free DNA is being shed by the placenta of the mother, and it is there in the mother's blood. So basically we are testing the mother's blood, we are taking the mother's blood and we are testing whether it has the fetal DNA and whether that fetal DNA has any abnormality or not. Now, this cell-free DNA it has a very short span of life and we can detect from as early as 9 weeks of pregnancy. So this cell-free DNA comes from the apoptotic cells derived from both maternal and the fetal. So what this test does is it differentiates between the maternal and fetal DNA, and we basically sequence the fetal DNA and make sure that whether the fetus is free of any aneuploidy or not. Now how this test works? So basically, based on the relative size of the chromosomes, what happens is it constitutes an a particular percentage of the whole genome. So this is basically a pure mathematical algorithm in which, based on the size and the number, and it constitutes a particular percentage, algorithm has been designed. Based on which we can say that yes, there is an increased percentage of trisomy 21 or not. So what is the testing technology? It is next generation based sequencing technology. Now how it works is, after the maternal blood is collected, we extract the DNA. Now this DNA has both maternal and fetal DNA. So basically we do the cell-free DNA extraction. We do the massive parallel sequencing, that is we sequence those strands. And then based on the alignment and the counting, that is the mathematical algorithm, we say that whether the fetus is trisomy 21 positive or not. Now this test is available as early as 9 weeks of pregnancy, unlike other biochemical screening markers which are available at a bit later weeks of pregnancy. We can detect up to as low as 2% of fetal fractions. Now fetal fractions plays a very important role, because based on the percentage of fetal fraction, it is we can actually have the confidence in the report that yes, the detection which has been done is proper or not. It can analyze all 23 pairs of chromosomes. What we require is just 10 ml of blood from the basically mother's blood. It can be transported at room temperature, so there is no risk to mother. The reports are available on 7 days. Within 7 days, what we require as in a document is the proper test requisition form. You know why? Because even what is the status of the pregnancy, whether it is an IVF pregnancy or the normal pregnancy, what is the gestation age, singleton or twins, because all of these factors are actually very important while we are performing the analysis. Now for whom this test can be considered? It can be considered if we have any positive screening test, if there is a previous child with aneuploidy, if there is an advanced maternal age. Actually, as per the latest SCOG guidelines, it should be offered to all pregnant females. It is validated for singleton pregnancies, twin pregnancies, as well as all the IVF surrogate mothers as well as donor egg pregnancy, because this test is based on whole genome based sequencing. For whom NIPT is not suitable, it is not suitable if you have detected any fetal anomalies on ultrasound. Suppose you have already seen there is something wrong on the ultrasound, there is no need in going for NIPT. We should directly go for the diagnostic testing via invasive methods. For triplet pregnancy, this test is not validated. Vanishing twins, that is the fetus has been reduced or it has been vanished, then make sure there is a difference of at least 6 to 8 weeks gap before you opt for NIPT, because it will result into false positive or false negative results. Last, if there are known genetic anomalies that cannot be diagnosed by NIPT, that is, suppose the previous child was having beta thalassemia, this test will not detect beta thal. So basically there are other testing options which are available. This test is only for trisomy 13, 18, 21 and 6 chromosomal aneuploidy. Now how the NIPT report looks like. This is a screening test. So suppose the report comes out to be low risk, that means it substantially decreases the risk of the targeted aneuploidy. So follow-up ultrasound is mandatory. If the test comes high risk, that means there is an increased risk of the particular aneuploidy that has been reported, but it has to be confirmed by amniocentesis, because there are chances that this could be a false positive. But yes, in all of those reports, what happens is we are also reporting Z scores. So based on the Z scores as well as the clinical correlation, we always give out what is the positive predictive value for that particular patient. So based on that, you will also be aware, yes, the percentage is 70 to 80% or 30 to 40%, or there is a borderline risk. In few of the cases, the result could be no call result. We will need a repeat sampling. Now the reasons behind the no call result could be low fetal fraction, high data noise, or the low sequencing reads. So all of these I will be showing in my next slide. What are the reasons for these no call results? And fourth, suppose after even receiving the repeat sample, we are again getting the same results. That is, there is a low fetal fraction or high data noise, then we would directly recommend to go for invasive testing. These are the factors affecting non-invasive prenatal screening test results. Low fetal fraction, yes, if the gestation age is early, more than 7 to 9, like if you have sent the samples between 7 to 9 or even till 9 to 11 weeks, it might possible that we might get a low fetal fraction in those cases. There is an autoimmune disease, heparin or aspirin administration intake. Most of the IVF pregnancies, what happens is they are continuously on heparin or aspirin intake. So this actually decreases the fetal fraction. So in those cases, it is actually important to take the blood at around 14 or 15 weeks, or make sure you are discontinuing the heparin before 4 days and then giving the blood. So at least if you have the no call result, make sure there is a pre-genetic testing counseling being done for the patient, and then a repeat sample is being taken. What are the reasons for high data noise if the sample is partially hemolyzed? The sample collection strategies are not proper. They are not shipped in a proper temperature because the tube has to be shipped below 25 degrees Celsius. The maternal age is very high. There are other maternal hematological disorders and a high gestation age, more than 25, 28. We have seen in those cases there is an issue of high data noise. There has been recently publications regarding that these two conditions are also related to fetal abnormality. Yes, if there is a fetal abnormality like especially 13 and 18, even in those cases we will not get the fetal fraction. So it is better to go for invasive testing. Maternal BMI is very high, weight is also high. IVF pregnancy, there has been latest two publications in which they have shown that if the IVF pregnancy has been done with frozen embryos, even in those cases, the fetal fraction would be very, very less. And if there is a maternal exposure to medication and other drugs, like if the patient is highly diabetic or having any thyroid issues, they are on insulin, high insulin, even in those cases we might get low fetal fraction. So whenever there is a no-call result, we make sure the patient is given proper post-genetic counseling before the repeat sample is actually being taken. What is the workflow and what we offer? So basically, as per the ACOG guidelines, 5 chromosomes are sufficient, 13, 18, 21, X and Y. But yes, based on the need, we are also offering Chrome Comprehensive that is being done for all pairs of chromosomes. And third is Chrome Plus, that is in addition to even the rare aneuploidies, that is 1 to 23. We also offer the 5 common microdeletions, that is 22, especially the Krydocheck, Digeorge and Predavilline. We offer the NIPT sample has to be taken in a specialized tube, that is a cell-free blood collection tube, which is known as TREC tube. And we have to ship it to the laboratory below 25 degrees Celsius, and after plasma separation we go ahead with the testing, and the reports are available within 7 days time. Now there are reports where we are seeing false positive and false negative results, but these are not in hands of anyone, because we all think that the exact chromosome complement is present in the fetus and the placenta. But what happens is many a times it is confined only to placenta, and fetus is all actually not showing what is there in the placenta, or there is a low level of mosaicism, that is less than 20% of the cells in fetus are actually positive. In those cases, we might get a false negative result, but this is a very rare event. And what about false positive? We are also talking about borderline positive reports, which might turn to be false positive in future. So with age, we actually, as the maternal age increases, we also see lot of abnormal cells in the maternal blood. So because the cutoff of this NIPT is very stringent, we might get a very borderline positive in the NIPT because of these abnormal cells. Now what is the positive predictive value? So with the biochemical test, the positive predictive value is very, very low. So that is the reason actually most of the number of false positive increases. But with NIPT, the positive predictive value is around 91%, which is combined for all chromosomes. Now in our lab, we have screened more than 25,000 pregnant females for NIPT, and we have seen that we have achieved a positive predictive value of 89%, combining all chromosomes. Now what is positive predictive value? It is a percent of positive test results where fetus actually have the aneuploidy predicted. That means 89% of the times when we have reported it as positive, it has come out as positive. What we do is, if any of the NIPT comes at high risk for 13, 18, 21 or any sex chromosomal aneuploidy, we offer invasive testing free of cost, so that the sample is coming to our lab and we are aware what has happened. Because many a times what happens is NIPT comes out to be high risk, there is a very high positive predictive value, and when invasive comes, based on the diagnostic testing they have taken, like suppose they have taken microarray turns out to be negative, but we know this is not possible. So in those cases we counsel them and we tell them that go for fish, because there are chances of mosaicism, and we have such cases and they are under publication in which we have seen that microarray is negative, but yes, there was a fish which was positive. But these are all technology issues, and we will we can take the call based on the results which are there in NIPT. Just summarizing about NIPT in one slide. It is available as early as 9 weeks of gestation. It is easy detection of chromosomal aneuploidies. It has over 99% accurate detection rate. No risk to mother or baby, as this is completely non-invasive procedure. It differentiates between the maternal and fetal DNA. It results in 7 days. It has a detection rate of as low as 2% fetal fraction, low false positive rates, and free genetic counseling is available before, during, and after test. Hope I have summarized this in a very simple way. Thank you so much.
Do we have any questions for Dr. Shiva?
Cost.
What is the cost?
It will vary from 8 to 10,000.
Since the test is so highly specific and sensitive, do you think in the near future double marker and the quadruple marker will be replaced by NIPT directly, or they both have a combined role to play?
See, as per the
Besides the cost.
Besides the cost, yes. As per the ACOG guidelines, what they say is, if you are opting for any one screening, go for that. If you are opting for double, go for it. If you have positive in that, go for invasive. So basically, patient have the right to choose between any of these, and I would suggest to go for NIPT. Yes.
Since it covers all the chromosomes.
All the chromosomes. Yes.
So patient should be offered.
Yes.
The choice will be the patient.
Yes.
As well as it is very early, can be detected after 9 weeks.
Yes.
So priority why it is NIPT? Priority is for NIPT.
Advanced NIPT and basic NIPT, when we send to some other labs, they give us this option whether you want to do basic or advanced.
So this is what we have shown. Like, every lab has their own the synonyms. Like what we have shown, chrome focus, they might call it as basic. So whatever lab, you need to know what all screening options they are offering you. Suppose basic has only 13, 18, 21, XY. Talk to your clinician, or you can take your decision what all things basically you want to get it tested. Every lab has their own genetic counseling being done. This test should be actually taken after taking a pre-genetic counseling, so that you are well aware what is this, if this is a screening test, what are the testing options available, what could be the results outcome, and based on that outcome you can decide ahead. But yes, as compared to double and quadruple, this is highly sensitive and specific.
Considering the cost, suppose if you come down for the cost, can you make it as a mandatory test for the lady who is certain age above? Because sensitivity being almost 99%, and you can predict the genetic problems. And if you are still you want to terminate or something, then you can take the radiological evidence, because 9 weeks is the time you are saying that this is the time you should go for the test. Not available before 4 to 6 weeks. And probably the radiologist will be there who can pick up the congenital a little later. So you can guide them in advance and take care of the baby.
Yeah, but then sir, this is not in our hand, this is government's decision. What we can do is we can only offer them. So nowadays every gynec, they are actually offering their patients and they are telling them what are the benefits of NIPT.
But you can, first of all, you can predict the problems in the pregnancy,
yes,
and avoid the future problems with the couple. No?
Yes.
Only the thing is that if the price is little less, the gynecologist will refer you more number of cases. Thank you.
Ma'am, there's a question for mine. Like my nursing home is registered as an ultrasound clinic. Can I send a sample for NIPT?
Yes, sir.
Because then you need to have the center registered as a genetic care clinic.
From Mumbai perspective, I have to, but no, it's not like that. Any female can take the NIPT test. Why not your center can send the NIPT?
I think we have to have the center registered as a genetic clinic. Only then you can send a sample. So I think we should clarify this.
I would answer that. In between this was an issue. Can I have a mic, please? Yeah, so this was there 2 years back when there was a recommendation from government that we have to collect those samples under PCP and supervision, but it has been removed now. So we can collect the sample
at any of the PCP and DT approved centers.
You will collect from home?
Yes, yes.
Thanks. Thank you.
Thank you.
Thank you, Dr. Shiva, for the wonderful talk. I request Dr. Ajay Shah to
Sanjay. I will request Dr. Sanjay Shah, senior gynecologist. And also I will.
For the next talk, we have a young dynamic gastroenterologist and endoscopist among us, Dr. Darshan Shah. He has completed his MBBS from MGM Hospital and Medical College and followed up with DNB in internal medicine from Sethi Hospital. He has completed DNB in gastroenterology from Bombay Hospital, and he was a Maharashtra state topper for the DNB gastroenterology exam. He currently has published 6 articles in various index journals. He has his own clinic in Borivali West named Mumbai Gastro and Liver Care Clinic. He is also visiting gastroenterologist in multiple suburb hospitals at like Tunga Hospitals, Apex Group of Hospitals, Nama Hospitals. He will be talking on the topic beyond stool and routine, what we have extra with the waste product of the body. Welcome, Dr. Darshan.
Of the stool test, apart from stool routine, which can help us in clinical diagnosis and in our day-to-day practices as well. So the most, going ahead without wasting time, the most common indication where we require a stool test is diarrhea. Now the diarrhea can be either acute, persistent or chronic. So acute is usually less than 14 days and persistent 14 to 30 days and chronic is more than 30 days. So the common indications where a patient presenting with acute diarrhea it depends on the severity. So severity of the symptoms with signs of hypovolemia, passage of more than 6 unformed stools in 24 hours, accompanied by vomiting, severe pain in abdomen and needing hospitalization. Second indication, it can be bloody diarrhea, which can be a sign of inflammatory diarrhea, and also patient running fever. It also depends on the patient factors, basically the host related factors which decides on the stool test. Common being age more than 70 years, multiple comorbidities in the form of cardiac disease, kidney disease, patient immunocompromised host, maybe HIV infection, post-kidney or post-liver transplant patients where the patient are immunosuppressants and presenting with persistent diarrhea, and IBD and pregnancy as well. Then symptoms persisting for more than 1 week for acute diarrhea, and then public health concerns like diarrheal illness in food handlers, healthcare workers and individuals in daycare centers. So the next stool test which we usually do after stool routine is a stool culture in acute diarrhea. So basically stool culture, the common organisms which we find usually is E. coli, Salmonella, Shigella, and depending on the culture and sensitivity we decide on the antibiotics. And also the type of E. coli usually, whether it is ESBL, non-ESBL, because sometimes if the patient is improving and the stool culture shows E. coli and it is resistant to most of the antibiotics, but the patient clinically is okay, then I don't think that patient requires antibiotic, because it can be just a commensal. Then going ahead, now this is one test which was discussed earlier as well, basically the BioFire panel in So it is also used in GI profile. It detects multiple bacteria, viruses and parasites. It's basically PCR test which detects genomes. And for this test, usually it requires a high degree of clinical correlation, because many times in biofire we detect multiple pathogens. It can be either multiple bacteria, viruses or parasites. So depending on the patient complaints, the severity of symptoms, the background history, whether the patient is immunocompetent, immunocompromised, and depending on the organism's form, it should be followed by stool culture as well, suppose if it is bacteria, because then it decides on the antibiotic as well if it is positive. So this is the panel which is done in Neuberg. It detects around 22 pathogens, various bacteria. Usually we are interested in different types of E. coli. Then there is protozoa, cryptosporidium, cyclospora. Now usually these parasites are found in immunocompromised hosts, especially in HIV infection or post-transplant patients on immunosuppressant. So, and viruses, maybe usually in children, it can be helpful because it's the most common cause of diarrhea in children. So, as you can see, it detects multiple pathogens, but again, I mean, we need to be correlating with the clinical situation. So, the downside, specimen collection and all, it's just technical stuff. It requires around 200 ml carry-Blair media, transport media is required. It can be stored up to 4 days. So this is one of the sample, one of the patient's test which was done. So you can see there are multiple pathogens detected, including E. coli. There were a couple of bacteria. Then there was Clostridium difficile. Then Campylobacter. Then So basically, my point is, suppose if Clostridium difficile is detected and E. coli is there, but patient with a history of recent antibiotic use or recent hospitalization, receive multiple antibiotics, I think we would rather treat Clostridium difficile rather than targeting E. coli. So basically we have to correlate with the history and the findings. Now coming to chronic diarrhea. Now why it is important chronic diarrhea, a couple of stool tests, because we need to differentiate the most common condition called as IBS from the pathologic disease. So a chronic diarrhea where there are alarming features in the form of blood in stools, mucus, weight loss, progressive abdominal pain. Then there is family history of IBD or colorectal cancer. So for such patients, we need to evaluate aggressively. Maybe the stool test will help for these patients. Now this is the common stool test which we perform for chronic diarrhea. We call it as fecal calprotectin. So basically it is secreted from the neutrophils. So wherever there is inflammation in the intestine, the levels of calprotectin increases. There is one more test, one more level which increases, which we call it as lactoferrin, but it is not done in usually in the labs. So calprotectin is common and has been studied aggressively in various articles. So suppose if a patient presents with chronic diarrhea, and we need to rule out whether it is inflammatory or IBS. Then the next test which we can offer, of course there are multiple blood tests to rule out celiac disease and all, but if we want to do only one stool test just to differentiate between organic disease and the functional disorder, this test will be very helpful. Suppose if it comes negative, then at least we know there is no organic disease happening in the intestine. So it distinguishes from inflammatory and non-inflammatory causes. It is the common condition which we are looking for when we ask for this test is IBD, whether it is Crohn's or ulcerative colitis. Then it also predicts relapse. Now the advantage of this test is it rises prior to 3 months of the symptoms. So suppose if you diagnose any patients with IBD, whether it is Crohn's or ulcerative colitis. So the first value of fecal calprotectin you will measure, and over a 12 months period, maybe every 3 to 4 months, you can just check the fecal calprotectin levels and find out whether the patient is responding to the treatment or not, or whether mucosal healing is happening or not. Why it is important? Because you can't just keep on doing colonoscopy every 3-4 months. Financially and also for patients, it won't be viable. So it predicts relapse. It can also help in predicting mucosal healing. Usually, most of the labs, the value is less than 50 microgram per gram. Now, suppose instead of 50, the value comes around 90. So it doesn't mean the patient is having IBD. I mean, the values are usually raised like more than 7-8 times in inflammatory bowel disease, or in fact in any inflammatory condition. So many articles have shown 100 as the cutoff value, and 100 to 250 for monitoring, and above 250 merits colonoscopy. So of course there are disadvantages. It's not a gold standard. It cannot differentiate among the inflammatory causes of diarrhea. So if the patient has TB or Crohn's, it cannot distinguish between that. Whether it is Crohn's, ulcerative, it cannot distinguish between that. So whether it is ischemic colitis as well, it won't be able to differentiate. So in fact even colorectal cancers. So it just shows that there is something happening in the intestine which we need to evaluate. So as I mentioned earlier, fecal calprotectin can help in the detection of response to treatment. So suppose if the patient diagnosed with ulcerative or Crohn's disease. So this was the study published in Lancet 2017. We call it as CALM study. And so it measured fecal calprotectin level over a 12 months period. It detected the first phase, it was divided into 4 phases. So the first phase, when there was selection for endoscopy and the fecal calprotectin level was measured, and then they started treatment for induction, which is phase 2. As you can see, the fecal calprotectin starts coming down, but it is not normal yet. Then comes the phase 3, where there is remission, and it remains in the target range, which is below 100 microgram per gram. And suppose in stage 3, if there is relapse, or if the fecal calprotectin increases, maybe at 9 months of starting treatment, and the patient clinically is okay, then we have to modify the treatment to bring back the fecal calprotectin level in the target range. That's how it helps in modifying the treatment. And the phase 4 is again remission, and just we have to maintain the FC in target range. The study measured only up to the 12 months period. Beyond that, it depends on the clinician how frequently he wants to measure. Now coming to the most common condition, GI problem, which is H. pylori. Now the indication for testing for H. pylori is basically dyspepsia or any upper GI symptoms in the form of heartburn, postprandial fullness. And so we have to categorize into 2 categories, basically 2 groups. Patients requiring endoscopic evaluation and patients not requiring endoscopic evaluation. So not in the second category, usually the stool test can be helpful. So in patients that are requiring endoscopy, usually the indications are age more than 55, recent onset dyspepsia, above age 60, then GI bleed, family history of stomach cancer, and diagnosis of maybe history of peptic ulcer disease in the past. Then usually not requiring endoscopy, less than 55 years, no family history, no bleeding, only for heartburn and dyspepsia. So usually when it comes to H. pylori, the concept is test and treat. So first you test for it and then go for treatment rather than empirical treatment. So stool test has like monoclonal assays usually we do. So it has got a 93% and 95% sensitivity and specificity respectively. It is a non-invasive test, that is the advantage. And it is cost effective. Earlier, I mean, it was shown that it It can be used in low prevalent area, but now it is like we can use even in high prevalent area as well. Only it can detect the eradication as well. So it can come negative as early as 7 days after the completion of treatment. But disadvantage being, when you test for the stool for H. pylori, the patient should be off PPI at least for a couple of weeks and off antibiotics for 4 weeks. Because if the patient is on PPI or antibiotics, it can come false negative. And we may think that patient is H. pylori negative and we may not treat. So, of course, we can also offer this test in patients not willing for endoscopy and no alarming features in the form of a GI bleed or family history or age. Now, this is another test which we usually do for stool for Clostridium difficile, toxin A and B, and GDH antigen as well. So usually this infection, earlier we used to think that patient with a long history of hospitalization or antibiotic use presents with this difficile, but community acquired Clostridium difficile is also becoming common now. At least whatever the articles suggest, it is now 5 to 10% among the Clostridium difficile infection, total infection. So patient presenting with severe diarrhea with WBC count maybe around more than 15,000, not resolving with conventional treatment, with a history of recent antibiotic use or hospitalization or immunocompromised host, then we have to check with for stool for Clostridium difficile toxin A and B. So the approach being usually it's an enzyme immunoassay which is routinely performed in most of the labs. So it detects GDH antigen, toxin A and B. So toxin B is usually more virulent than toxin A. And so these are the various categories. Suppose if both is positive, then there is no question. I mean, the patient is having Clostridium difficile. We treat with vancomycin for 10 days and see the response. If the antigen is positive and toxin A and B is negative, then we ask for a nucleic acid amplification test, which usually detects toxin B. So if that comes negative and the clinical correlation is there, then the patient is Clostridium difficile negative. But if the NAT comes positive, that means the patient is Clostridium difficile infection is having that, and we will treat with Vanco. Then both are negative, again, not consistent with Clostridium difficile infection. So even if antigen comes negative, toxin comes positive, we treat it as Clostridium difficile, at least in clinical practice, because we can't keep on performing NAT for this thing, because we need to start treatment. Patient is already in sepsis. We need to give vancomycin as early as possible, maybe combined with IV metronidazole. And if patient not responding, maybe later on fecal microbiota transplantation can be the last choice. Now, chronic pancreatitis, the stool tests are all obsolete now. Just for theoretical purpose, we'll discuss in short. I mean, by the time the stool comes positive, patient CT, MRI, US, everything is done, and we have the diagnosis of chronic pancreatitis. And again, stool tests are quite cumbersome. But earlier they used to check for stool for fat excretion. If it is more than 7 grams, patient has steatorrhea. And the last is Sudan stain. Sudan stain, usually Sudan 3 stain is used. If there is more than 6 fat globules on stool, then it's chronic pancreatitis. Now this is the newer concept. We call it as liquid biopsy. Like what tissue biopsy is usually called solid biopsy, and if the fluids are used, as the name suggests, it's called liquid biopsy. So in US, they have started using stools for detection of colorectal cancer. Basically, they check for the circulating tumor DNAs or circulating tumor cells, various microRNAs like 1321, 134 for detection of colorectal cancer in the early phase. There is also one stool test which can be combined with DNA testing. We call it as fecal immunohistochemical testing, which detects hemoglobin in the stool. So it has been now approved in US for screening and surveillance of colorectal cancer. The guidelines says that every 3 years we can check for FIT and stool DNA testing to detect early colorectal cancer instead of going on doing colonoscopy or colography or CT colography. So this is the newer concept. Maybe in few years down the line, this will come into picture. So to summarize, for acute diarrhea, again, stool non-inflammatory causes. Then H. pylori stool antigen, again, with a good sensitivity and specificity will be really helpful as a non-invasive test, helps in, to detect eradication of H. pylori, and it is also cost effective as well for the patients. Chronic pancreatitis, it's obsolete now, but colorectal cancer, I am hopeful stool DNA testing and FIT will come into picture very soon to detect even surveillance in India as well, because colorectal cancer, the frequency and the prevalence is increasing now in India. Even we are detecting at earlier age as well. So this will be very helpful in the near future. Thank you. Thanks.
Questions? Dr. Darshi, thank you. That was a very nice session. If with your permission, I could make a few comments on the microbiology aspect.
Yes.
So basically, my comment is on stool cultures. One of the most common pathogens, I agree, is E. coli. That has to be serotyped, and most of us laboratories really don't do serotyping. Amongst the pathogenic E. coli, the only one that is probably important from the point of view of antibiotic therapy would be enteroinvasive E. coli, which you will very clearly come to know with a stool routine, which will show pus cells, plenty of pus cells and plenty of red cells. The remaining ones, enteroaggregative, enteropathogenic, there's a third variety as well. All of these, EHC, yes. So none of these really require antibiotic therapy. And in fact, it is said that if you give antibiotic
Hemolytic uremic syndrome.
Yes, apart from hemolytic uremic syndrome, you may also have increased toxin production and therefore severity in the disease presentation subsequently. So apart from the invasive ones, which again we don't detect in the laboratory unless you do a GI-PCR, nothing else really warrants an antibiotic regimen. With regards to the biofire, unfortunately it misses out on microsporidia and isospora, two very important pathogens from the HIV subgroup, meaning from patients with whom you might suspect of opportunistic infection. Thankfully for isospora, it's a very easy diagnosis. The stool routine itself will show very characteristic features, and of course the 1% ZN would help you with at least 3 of these pathogens excepting for microsporidia. The third comment is again on E. coli and the ESBL that you mentioned. Please do not go about treating patients of E. coli with ESBL because they are really not pathogens.
Yes.
They're simply present in the gut and they don't really have much of many clinical implications. The fourth comment that I'd like to make is about Clostridium difficile. The algorithm for US is the two-step algorithm, and naturally we know they have a lot of cost implications. And that is the reason why they adopt a two-step approach. I think in India, most of us, laboratories, small, big, today have the gene expert, which is a molecular-based assay, and most of us do our TB diagnosis on the gene expert. So that same system has a NAC-based assay, which will give you Clostridium difficile in addition to the ribotype O27. So our first approach should actually to diagnose CD should be a NAT rather than a toxin assay, because the sensitivity of a toxin assay is only about 60 to 70% versus a NAT which is almost to the tune of 90 to 92%. The only drawback of a NAT would be it's not a prognostic assay, it's only a diagnostic assay. You have to do it only once. It cannot be done to assess whether the therapy is working. And anyways, whether the therapy is working is only a clinical decision making, not really dependent upon any laboratory. Thank you.
Thank you. Thanks.
Any other question?
Thank you, Dr. Ajay, for highlighting on the advanced fecal testing. I just wanted to ask how much is fecal calprotein useful in chronic diseases like diverticulitis, because they are supposed to be very recurrent, and can you put some highlights on that?
So, fecal calprotectin for diagnosis of diverticulitis
Maybe
is
the prognosis pattern?
no.
Okay.
I mean, diverticulitis anyways will pick up on based on the symptoms and the CT scan. And we know we don't have to differentiate among any inflammatory disease. I mean, we know it's diverticulitis. There is no point in sending stool for calprotectin. It won't. We just give antibiotics, the diverticulitis settles down, that's it.
So even in the inflammatory process of the diverticulitis, it might help or it might not?
No. So it will be raised. But anyways, if the patient improves clinically, the calprotectin will anyways come down because the inflammation is settling. But it's not a chronic thing which diverticulitis, if it keeps on happening and all, then it's a different ballgame.
Thanks so much.
Thank you.
Then this liquid biopsy. In liquid biopsy, at what stage of cancer is it detected?
No, so it depends on the history. It's still in the process of trials. They are studying various microRNAs based from the samples taken from the patient already having colorectal cancer. It has not come into picture yet, the full-fledged, but they are testing stool DNA and FIT DNA. Basically, they check for KRAS mutation in the stool for prediction of colorectal cancer before the patient having actually the colorectal cancer. So this has been started in US, where they screen every 3 years for FIT and for stool DNA. So liquid biopsies will take time, I guess.
So if you want H. pylori testing, we have to be, patient has to be off PPI for a few weeks.
For 2 weeks.
And if the patient, we can put on H2A antagonist or?
No. So off PPI or H2A.
So it will be
Yes.
more time. And any stool test to diagnose IBS, or IBS is more of clinical?
No, IBS is a diagnosis of exclusion. There is no test for as such IBS.
Okay.
I mean, it depends. If the patient is having constipation and all, you can just rule out other disease by doing anorectal manometry or something like that. But again, it's a diagnosis of exclusion. We just have to manage with medicines and counseling. That's it.
Thank you.
Yeah.
Thank you, Dr. Ajay, for this wonderful talk, and I will call upon stage Dr. Ajay Shah, sir, for felicitation.
Dr. Mahendra Dr. Kamdar, sir. Very senior anesthetist.
So thus we come to the last lecture of this academic feast. This cannot end without something which has created a havoc in last 2 years, that is COVID. Though COVID is, we hope to end, COVID end sooner, it has come up with a lot of sequelae, and so the next topic is on that. I will call upon stage our next speaker, Dr. Vidyalata Koparkar. She is one of the few formally trained and National Board certified infectious disease specialists. She is practicing since last few years in Borivali area. Dr. Vidyalata has been trained in ID at PD Hinduja Hospital. Additionally, she has received diploma in tropical medicine from CMC Vellore. She has authored a book chapter called Basics of Drug Therapy in COVID, published in Casebook of COVID-19. She has many national and international publications and has been invited as a faculty at various conferences. So I welcome my colleague and friend, Dr. Vidyalata.
Dr. Ajay Shah sir and Dr. Sagar Shah for inviting me for this topic, which is actually, as she said, Dr. Prasida, that it has created havoc for all of us in the last 2 years. So quickly we begin. It's an unprecedented pandemic, more than 6.31 million deaths, varied presentation, multi-system involvement, multiple treatments, multiple vaccines, no definitive therapy yet. Variants in coronavirus are unparalleled. Coronavirus is not known to mutate that much, but here it is really unparalleled. Long-term effects, this is what we are going to try and discuss here today. So the term long COVID was first used by Perego in social media to denote the persistence of symptoms weeks or months after initial SARS-CoV-2 infection, and the term long haulers was used by Watson and Yang. We have a complete guideline that is published by the Ministry of Health and Family Welfare on the management, diagnosis and management of post-COVID sequelae. And many of the parts of my talk are actually taken from here as well. The other guideline base is the CDC USA, and here they have said that approximately 1 in 5 adults will suffer from post-COVID or long COVID syndrome. As the disease had varied presentations, anything and everything was possible in COVID, so is it in long COVID. It can be neurological manifestations, cardiovascular, kidney failure, respiratory, musculoskeletal, and even blood clots and vascular diseases that occur even after more than 3 months after COVID. So the definition, this definition is actually taken directly from the ministry booklet which we have. The post-COVID syndrome by consensus is defined as signs and symptoms that develop during or after an infection consistent with COVID-19, which continue for more than 12 weeks and are not explained by alternative diagnosis. So again, it becomes a diagnosis of exclusion. Long COVID is the same term, NIH, UK use it, so these are synonyms basically, post-COVID or long COVID. Now they are classified into 2 subgroups. One is the subacute or ongoing COVID, which is up to 12 weeks. So acute COVID is actually up to 4 weeks. 4 to 12 weeks would be the subacute or the ongoing symptomatic COVID. And chronic COVID is one which persists beyond 12 weeks. So whatever data we have that they have analyzed is up to 6 months. The follow-ups have been typically up to 6 months. So this is just the schematic presentation of the same thing that I mentioned. So actually the post-COVID comes after 12 weeks. And now the terminology used for symptoms between 4 and 12 weeks is ongoing COVID. Now here, this is actually taken from the CDC. There are various publications which talk about the numbers being really different. So what I would like to highlight here is more than 30% at 6 months among patients who are hospitalized. So clearly the incidence is much more in hospitalized patients than the non-hospitalized. The readings are up to 55%. There are various studies, they talk about 55% post-COVID syndrome in admitted patients. What is the pathophysiology? So here, the viremic phase or the immune phase. Either by viremic phase by direct organ damage, cytokine phase by the secondary organ damage. Altered immune state is used to manage the cytokine storm. And secondary infections coming out from there. The essential problem is the degree of organ damage, even the drug and drug-induced side effects. So all of that will lead to prolonged symptoms which constitute your long COVID. So it's the degree of organ damage which is responsible for this long COVID. So what are the various manifestations? As I already mentioned that everything, all systems were involved prominently during COVID, so is the case in post-COVID syndrome. The most common which we see is the profound fatigue or the chronic fatigue syndrome. Then there are various cardiovascular, gastrointestinal, renal, neurologic manifestations as well as respiratory. My arena of expertise is on the persistent fever. Now persistent fever is actually less commonly seen after 12 weeks. What we are seeing, the fever issues are usually up to the first 12 weeks only. So it doesn't come in the classic post-COVID or the chronic COVID definition which is seen beyond 12 weeks. So the first and the commonest symptom of long COVID is the chronic fatigue syndrome. Here the essential criteria is that substantial impairment in the ability to perform activities. carried out prior to the disease for more than 6 months. Profound fatigue which is not relieved by rest, discomfort or aggravation after physical exertion, and unrefreshing sleep. In addition to this, if there is cognitive impairment, then the condition is called as myalgic encephalitis and orthostatic intolerance. This orthostatic intolerance is not a mandatory feature of myalgic encephalitis, but it can be an additional point in chronic fatigue syndrome. The most common cardiovascular manifestations are chest pain and palpitations. So chest pain is reported in about 20% at the end of 60-day follow-up and 5% at 6-month follow-up. Palpitations respectively at 10 and 9%. Stress cardiomyopathy compared to the pre-COVID era, it is 4 to 5 times more common. And 5% venous embolism events which are noted up to 6 months post-acute COVID. Gastrointestinal, again, everything is there, nausea, vomiting, loss of appetite. The most common is actually altered bowel habits. Hematemesis, melania, dysphagia, GRD, all this is defined in various studies that we have. The risk factors again include severe disease, old age, and drugs. So this is an important thing, that drug-induced problems of the liver, that is transaminitis, which we see with the commonly used drugs, that is the remdesivir, favipiravir, molnupiravir, as well as with the tocilizumab. So these are important contributors to the hepatobiliary disease post-COVID. Renal, the most important ones is the new onset AKI, progression of the CKD to end-stage renal disease, whether it's a native kidney or a transplant kidney, new onset glomerular disease, new onset hypertension or worsening hypertension. So the symptoms of presentation are just the usual like fatigue, nausea, anemia, headache, pedal edema and such things. So there's no difference in presentation. 46% of severe COVID and ICU admissions, and 20 to 30% of them requiring renal replacement therapy. 1/3 of the people who had AKI during COVID, they will not have their baselines return to normal. And the CKD overall prevalence at 6 months is up to 5 to 20%. Neurological. Now the neurological manifestations in post-COVID, now this is more common somehow in the Western world, maybe because of the overall elderly population over there. So brain fog, that is the most common symptom of post-COVID if you see the US data. And that is difficulty thinking or concentrating. Headache, sleep problems, dizziness. Now this lightheadedness or orthostatic hypotension, these are very well described. And of course, the change in smell or taste, that is even seen in patients who had a very mild disease actually. Pins and needle sensations, depression or anxiety, and even clear-cut cases of GBS. Now here, the reason why we see various, this thing is the bias actually. The symptoms range from 10 to 87% in various studies. So we don't have an exact prevalence of the neurological manifestations in long COVID, and that is related to the small sample size, the recall bias, the various definitions of post-COVID sequelae, and because these were all in the initial wave, that is in the 2020 wave that we have the data that for long COVID. And here they have been various definitions. I mean, it is not, some people have evaluated it at 2 months, some have evaluated it 7 months. So that is the difference why the prevalence ranges so variedly. Again, the risk factors remain the same. This is one thing that I would like to point out, that is the dysautonomia which presents post-COVID. Dizziness and palpitation, stress intolerance, chest tightness, pre-syncope and syncope, which is very classical. I mean, if you see the POTS, there is no drop in hypotension, there's no hypotension, there's no postural hypotension. It is just the tachycardia which comes up within the first 10 minutes of adopting the upright posture. And the difference has to be 30 beats per minute for adults. I already mentioned the brain fog. It is critical care neuropathy and the ICU psychosis and such things only worsen these conditions. Respiratory, persistent complaints of shortness of breath, dry cough, and chest pain. Age above 60 years, smokers, diabetic, hypertensive, coronary artery disease, pre-existing lung diseases, oxygen requirement at home that were discharged on oxygen therapy, and who required any sort of mechanical ventilation or even non-invasive ventilation. These are the high-risk factors for post-COVID pulmonary sequelae. So this again is directly from the textbook, where they have tried to mention so essentially it's very important that for any case of chest pain, breathlessness, hypoxia, you rule out a new onset pulmonary embolism, myocardial infarction and pneumothorax, because this can occur any time, even if the patient had mild disease. Fever has to be looked into with whether there is a secondary infection or it's just a in secondary, or it's an otherwise healthy person. It can be the only manifestation of long COVID. This is one thing that I would like to bring to everybody's notice. That is, this is an article. Actually, this is from April 2020 to December 20. Now, this was patients who were not hospitalized for COVID. Still, we are seeing about 12.8 to 27.8% of long COVID sequelae in these patients. So they might end up having altogether, their illness was extremely mild, but it's after 3 months that they are presenting with any of those syndromes that I have just mentioned. So this was the study, that 958 participants were there, and about 12.8%. But the most common thing that they had was anosmia, ageusia, fatigue, and shortness of breath. And even in the 6 months, the percentage remained the same, actually 12.8. How do you manage long COVID? There are multiple and beautiful diagrams there, but essentially what all it boils down to is rule out via clinical examination and lab and radiological diagnosis any alternative cause for this, because there's nothing to mention directly. No amount of COVID antibodies or no tests or any CT values will correlate with any long COVID syndrome. Management of comorbidities, supportive therapy, specialist referral, and continual assessment and teaching patient about self-monitoring. That is essentially the signs and symptoms and your oxygen saturations that you would educate the patient on. This brings to the topic where I am commonly involved when there is fever in COVID patients. So secondary infections, that is VAP, CRBSI, or catheter-associated UTI, that is all in severely sick patients who are in the ICU. Inflammatory, so this is especially in immunocompromised patients. In immunocompromised patients, the persistent fever, patient will not be hypoxic or the patient will not have any other symptoms, but their fever just persists. Especially patients who have received chemotherapy, transplant recipients, the manifestations are so delayed, and these patients are typically repeatedly RT-PCR also positive. So even at 4 weeks or beyond that, we have seen immunocompromised patients go into cytokine storm. So that is one thing which you have to be very careful with immunocompromised individuals, a delayed cytokine storm. Even in otherwise stable patients, as the only presentation of long COVID, many of the physicians must have seen this, and they often respond to the NSAIDs or short dose of steroids. And that is the exact reason why we probably don't see it persistent beyond 12 weeks. Thyroiditis. Now this is a very missed diagnosis because the patient can present here with the palpitations, fever, high WBC counts and diarrhea. And people really miss on the thyroiditis as the cause of this particular condition. And it's a very well known and well described entity in the post-COVID patients. To wrap up the presentation, there's a small case which I had seen in last year, April 2021, that is. A 33-year-old male who had RT-PCR COVID positive in the first week of March 2021. It was a mild illness, he was in home isolation. He was admitted elsewhere on the 17th of April 2021 with complaints of fever, rash and diarrhea. These are his few of his clinical parameters, WBC count, the laboratory parameters. WBC count was 18,000, there was a 25,000 report. Platelets which were typically between 1 lakh to 1,50,000. CRP is very high, 280, 340. High PCT, 24 and 36, twice it was done. Patient was currently RT-PCR negative. So I am seeing this patient on the 27th of April, I'll show that later. And the patient had COVID in the first week of March. SGOT, SGPT were definitely raised, it was 250 and 278. Creat was normal, D-dimer was extremely high, 6.3. Cutoff was 0.5. Blood urine cultures, they were done twice. They were all negative. Before seeing me, the patient had already received meropenem, vancomycin, teicoplanin, colistin, remdesivir, pulse width, prednisolone, and actually they had called me to ask whether amphotericin is indicated. Fluconazole I missed out in that list. It was a worsening condition. This was a video consultation. The patient was admitted elsewhere. It was a toxic look. He was on NIV support, but if you see that, we rarely saw that the FiO2 is only 30%. So the requirement of oxygen in a COVID patient is very, very high. He is not going to be stable at 30 and 40% of FiO2. Noradrenaline support was there, but it was minimal. The CT chest, I don't have the films from, but I have the report ahead. It was pulmonary edema. CT chest abdomen, the abdomen was within normal limits. Echo, I really don't know how much to rely on that. One was 50% and the repeat one was around 35%. So this was the rash actually. That's the picture that I had on the first day. And this was the, it read about, it did mention about a CT score of 12 by 25, but it was very clear in saying that there is more likely chances of pulmonary edema. And he had bilateral pleural effusions as well. So the possibilities here, they had already considered cytokine storm, bacterial sepsis, mucormycosis, pulmonary embolism, but all these to me were a little less likely. Cytokine storm, CT doesn't show a pulmonary edema typically. Myocarditis, yes, if it was, but he didn't have any arrhythmias. PCT was high and that cannot be explained by a cytokine storm. Pulmonary mucormycosis, there were no clinical features, there was nothing on the face, there was CT, that CT was not suggestive of a pulmonary mucor, which usually has very big nodular consolidations. Sepsis, there was no focus, there was no response to antibiotics, almost all antibiotic was thrown at him. Pulmonary embolism, again, no evidence on echo. Rash was very difficult to explain. I had asked for a TROPA CPK MB looking at all that and they were very strongly positive. So actually for me this was a multi-inflammatory syndrome. That is, it is in adults. It's a rare thing in adults. It is very well described and common in children. Common and fever, so any of these in the layman's term can actually be the presenting feature along with fever. If you see the clinical criteria, it's fever plus 3 clinical criteria. Now out of the 3 clinical, one has to be a primary clinical. So there's primary clinical and secondary clinical criteria. Primary clinical criteria is actually cardiac illness. It can include even arrhythmias or LVEF of usually less than 50%. Rash. This patient had rash as a presentation to begin with. Non-purulent conjunctivitis. My patient did not have, but I have just highlighted the ones which this patient had. In the secondary clinical criteria, it can be neurological signs and symptoms. It can be meningeal signs, it can even be GBS. Abdominal pain, vomiting, diarrhea. He had diarrhea as a presentation and thrombocytopenia which was present from day 1. So the laboratory evidence is actually the patient may not have a current COVID RT-PCR positive. From the time of presentation, 3 months, within that 3 months prior to that presentation, patient should have a COVID RT-PCR positive. This patient clearly had a positive report in the first week of March. His presentation was mid-April, and at that time, the mid-April COVID RT-PCR was negative. And elevated levels, so this is the thing that I want to highlight, that we all know CRP, ferritin, IL-6 can be elevated in multiple conditions, but so is PCT. The high PCT, many people consider it as a bacterial indication only, but MIS is very, very important cause of high PCT. So that becomes difficult for us to use immunosuppressants so clinical interpretation becomes very, very important. This patient was treated with immunoglobulins, IVIG, 2 grams per kg was the total days given over a period of 5 days. And he responded actually very well. On day 3, the fever resolved, and 1 week after the therapy of IVIG was over, he was discharged. So in summary, long COVID may be seen in 5 to 20% of COVID cases, more so in severe COVID. Now the literature, latest literature what is there in Lancet says 55% in admitted severely cases versus up to about 25 to 30% in non-admitted cases. Any organ system can be involved. Out of this, fatigue, brain fog, dyspnea, chest pain, palpitations and altered bowel habits are the most common presentations. Fever, as I said, usually as ongoing COVID rather than So with these various variants and the current one with BA2, for me COVID is a mirage. I don't know where it's going to really end. Thank you.
Questions?
IVIG was given when after all the antibiotics were tried and
everything was tried. I mean, I was involved at the case when everything was already given. So within the first 11 days, everything was given to him. I told him, the question to me was, amphotericin bhi dena hai kya?
So IVIG worked.
If you make a clinic, this is a clinical diagnosis, and as I said, exclusion, you didn't have anything else. That's why exclusion things. Sepsis was reasonably excluded. There was no focus, no cultures positive, CT is normal, CT chest showing a pulmonary edema. So IVIG, I mean, I didn't feel it was anyway infective. And see, he's a patient who was sitting in the community. Why do you even need colistin? I mean, just 10 days of hospitalization, and from the day one he was like that. There was no difference in whatever his presentation baseline was.
Madam, this neurological presentation was seen more in acute, subacute or chronic, any idea?
It is more in the severe, you mean to say in the acute COVID will not be a part of long COVID. So ongoing COVID as well as chronic COVID, the frequency is 12.8% for the simple ones, that is AUCI, anosmia and such things. The brain fog and all that is there, it is equal. The presentation, because the brain fog and everything is more described in severe cases. So at 6 months, chronic COVID also the frequency is very much as similar to the ongoing COVID when it comes to brain manifestations. However, for the chest manifestations, there was a clearly decline after 3 months, after 12 weeks, that is, yeah.
In your thing, you had mentioned one of the in CNS involvement is Guillain-Barré.
Yeah.
Again, any idea which was the stage? Was it subacute?
Subacute.
Subacute. Because
I don't know, neurologists, if they are there, they might have a different opinion, but whatever literature I have, because it will not come to me directly, whatever I have seen was in the subacute phase.
No, it must be in subacute stage, because
and the literature of Lancet, whatever it mentioned.
Yeah, no, what I am telling you is, usually this Guillain-Barré is supposed to be immune complex.
True.
So there has to be antibody
to
cause these. Now we had one patient who, young girl of 16, she came with classical Guillain-Barré and we had to give her immunoglobulin and she came around. Only positive thing was, it was not of course COVID but following vaccine.
COVID vaccine?
Yes, yes. She had taken co-vaccine 3 weeks back.
Okay.
So probably, I mean, this Guillain-Barré and all must be coming up in second or rather subacute.
Yes, because if you see, the same literature
it was
actually,
following a vaccine.
the same literature actually also has the immunoglobulins level. And you see a clear decline between that 3 to 6 months of immunoglobulins.
Have you come across the case of a vascular necrosis of the paper head? Is it described?
So that is secondary to steroids. I mean, yes. But none of, fortunately, my follow-up patients presented. But we definitely have these patients going to the orthopedicians with chronic pain and they turning out as avascular necrosis.
Thank you.
Actually, back there, Dr. Aruna Pujari had asked me one question, and she's not asked it here. But actually, she had asked me if there is a difference between the Delta and Omicron variant in long COVID. The data is just recently out, and that is actually Delta had more, because if you see the severity of the illness was sheerly more. So it is real, the pathophysiology surrounding organ damage. So definitely, we hope that the incidence of long COVID decreases as the vaccinations are better, and the overall COVID virus miles down in terms of severity. So that
Madam, I would like to ask you, nowadays patients come with home kits or this thing, that means they come with the kits which are sold in the chemist shops, and and they say that it is positive, And I would like to know what is the protocol for giving treatment to them. That is one. And how do we then inform the municipality about this case?
Actually, ideally, the chemists are supposed to record that, and there is a clear-cut indication on that rapid antigen kit that the patient himself has to take a picture of that and upload it onto the BMC site, which obviously nobody is going to do. So whether up till now, at least thankfully, the onus has not been thrown on doctors for that we have to take a picture and upload it. Thankfully, we are not. We can only advise RT-PCR, and my protocol is that if the patient is otherwise asymptomatic, we know the BA2 variant, which is the current variant, has got, it's a less severe agent, of course. So just symptomatic treatment in whatever you asked me.
Madam, have you come across mucormycosis cases?
Multiple.
But there should be subjected
Not in post Omicron, they are very, very less, but post Delta, they are quite significant.
They had to undergo surgery?
Yes, so in that mucormycosis, if you see the range for the development of post-COVID mucor is from day 6 to day 52. And the median onset of mucormycosis is actually at day 19 to 20. That's what they have said in various literature. So that's how it presents. So you have to alert your patients for all those signs and symptoms of headache and headache or whatever. They might have nose blocks, some have exclusively dental manifestations. So you will have to educate them to look for these. That's why I gave you the range. It is from 6 to 52 days. So you see, you can fairly tell them for the next 2 to 3 months. You have to be observant for this.
Maxillofacial problem.
Yes. Of course, overall pulmonary mucormycosis was very rare. We saw mainly rhinocerebral and orbital.
Reinfection with Omicron also? I mean, it's very rare.
Reinfection is very well known. No? We have seen multiple cases of reinfection. Yes. So if I got a BA1 variant of Omicron in January, I might get BA2 Omicron now.
So we are out of BA1 now and it's only BA2 which is...
The current circulating strain is BA2. Dr. Prasida, if you have a genomic data on that.
Any personal experience you have post-vaccination? We are getting so many cases of the thyroiditis. Have you got any patients? I have seen 2-3 patients post-vaccination, mostly Covishield, they have this thyroiditis.
Post-COVID vaccine thyroiditis, I have not seen as common as the post-COVID thyroiditis.
Post-vaccine?
Post-vaccine only. My experience is that more COVID infection per se has caused thyroiditis than the vaccine itself.
Madam, I will come across, now you want to say...
Gone up, and after 3 months again without any medication it came down to normal.
So that is the typical, so you have the viral thyroiditis or the subacute thyroiditis which actually resolves spontaneously. So you are trying to say that you have seen it more post-COVID vaccine, that is more post-Covishield rather than the COVID infection itself. Okay, my experience is actually more to see it with the COVID infection.
Last 7 days I have seen 3 cases. Do you want to say anything on that?
Of what?
RT-PCR, COVID positive. Last 7 days, 3 cases.
I think the numbers are rising. I mean, we all know about it.
No, you want to say any precautionary measures or is it going to go?
At least when you are
you have to suspect because in between as a surgeon, people used to avoid doing RT-PCR because it was outdated. But now pre-operative we have seen RT-PCR positive.
See, actually, there is a good data to say that the patient's outcome post-surgery does not get affected with the patient being COVID positive or negative. Now, that is quite pretty clear. Now, this is more from the infection control perspective, that whether you want to do a pre-COVID testing.
That may be from the patient point of view. What about the operating team?
So that's what I'm saying, from the infection control point of view and the operating infection control and the safety of other doctors and your paramedical staff as well as your other patients. So it is more important from that perspective.
Because if it is under general anesthesia, entire team can get affected.
So you cannot let your protective gear off. If you are not testing or whether you are testing, you cannot let that
You
gear.
do RT-PCR positive, hold on the surgery for some time and then go ahead, no?
There has been a lot of debate on this. Every surgeon will want to have his own views, but at least it's not going to affect the outcome of patients.
It is a 5 days. Generally, the patient is infected only for 5 days.
No, actually, the real infective period is still 10 days. You know, so we are saying that 10 days is still very much patient can shed virus and infect. So total 10 days of isolation is what? 7 to 10 days at least we have to isolate the patient.
With your permission, if I could add on the infection control
Yes,
perspective.
please.
So I think we have to take the analogy of HIV, HBV, HCV. Currently, we consider every patient as positive for bloodborne viruses and take precautions whenever we are performing any invasive procedures. I believe we are entering into a phase of COVID where we will have to do the same with COVID also. You know, consider every patient as maybe COVID positive because it's very difficult to keep testing patients all the time. We've not reverted back to pre-surgery testing as we did earlier for the Alpha and the Delta waves.
Thank you, Dr. Vidyalata, for sharing that interesting case and very good discussion. Thank you to the participants also for very good participation. I think you all have got feedback forms, so kindly fill those forms and submit it to us. I'll call upon stage Dr. Ajay Shah sir for felicitation.
I will call Aishwarya Vasudevan, Group CEO. She has specially come from Chennai for this session to
I'll call upon Dr. Sagar for vote of thanks.
So, very good afternoon to all, and it gives me an immense pleasure to deliver this vote of thanks on behalf of the entire organizing team. At the onset, I would like to thank all the distinguished guest speakers for giving their time and sharing their deep insights on their talk. Secondly, I would like to thank each and every delegate who has attended this CME today, and it's because of you that it is such a success today. Lastly, I would like all of you to fill the feedback forms. It will help us to understand which topics we can cover in our future sessions and make it even better. So thank you each and everyone, and lunch is served.
से पहले चले जाओ।
कब निकाल दिए कभी करता ही मैंने पेट दिखते सब शर्ट पे अच्छा अभी तक अच्छा
Son speaks well. next time keep one session with him.
Sure. Talking to
yeah.